really was part of my plan beginning, because now we're looking at the upper extremity. I gotta wait and see, okay? So hopefully I'll know by the end of today whether we're gonna be able to use the Biodex for any of our upper extremity lab activities. We'll see. I'm hoping that they'll be able to kind of cordon off the rooms because they're going to be working mostly on just that exterior wall. So we might be able to access just that area where the Biodex is located. We'll see. I doubt that they'll move it because it does require specific circuitry. It's not easy to set that up in a short time. We'll see. We're waiting to find out. But we're probably not going to be able to use that room for the rest of the semester. And all that's good. By the time they get all this construction. We'll see. It just figures, right?
Yeah.
And so the other thing is, what we're going to be covering between now and the next exam is all the upper extremity chapters, which is basically 5, 6, and 7. We're starting with chapter 5 today. So your next exam will be on shoulder, elbow, forearm, wrist, and hand. Okay, everything from the upper extremity. We won't do spine, head, neck, and spine until after your next exam. So that exam, depending again on how we get through this, it's looking like it would probably be in the first Wednesday in November. Okay? Now obviously I got to build in some flexibility there, but it most likely would be that first Wednesday. Then that following Monday would be your first practical, which will again just be the upper extremity. Okay? So you would have your written exam on Wednesday. I will give you, after that exam, the lab will be open, so if you want to go in and do some review for your practical on the following Monday, you'll be able to do that after the exam. There'll be plenty of time to do that. So that's the tentative schedule between now and your next exam. Okay? This exam, I want to go over a couple of questions. Well, it's about half a dozen, or a dozen questions or so. Yeah?
This might be a dumb question. Might have got over it on day one, but I was about 45 minutes late.
The practical?
What do they entail? Yeah, practical.
We'll talk about this again, but basically you're going to be starting in lab today. You're going to start to get back and reviewing your bones, specifically looking at particular body landmarks. Okay, and they are notable because of attachments of perhaps muscles, ligaments, notable ligaments, nerves that may be associated in that area. Again, you might be asked to describe, okay, this bone comprises a joint. What type of joint is it? Okay, so it's going to be questions identify and something associated with what you're identifying with that body landmark or that bone. Yeah.
And is it the whole body or is it just?
No, it's just the upper extremity. It's only going to, no. We're only going to do, right. We're going to do upper extremity. So again, we're going to be talking about that. So upper extremity is going to mean scapula and distal. Okay. All right. Now in terms of the exam, a couple things. Number one, I can tell you the average grade was an 81. Okay, which is not bad. There are 2 questions that I'm throwing out, and I'll explain why. So that means if you got 40 questions correct, and I'm throwing out 2 of the questions that you got correct, you're not going to be penalized for that. You have 40 correct answers out of a possible 48 instead of 50. Okay? So nobody's going to get penalized because I throw out a question that you may have answered correctly. Yeah?
So our grades might change.
Your grades have changed.
Oh, they
So
have
if you,
changed.
yeah, so if you look online, okay, if you look online, and you can review the exam through your Moodle room now. Okay, you should be able to see, those of you who took it online, a couple of you did not. You can review your exam now. So whatever you're seeing as your grade, you're adding 4 points to that exam. So if you got an 80, if you got 40 out of 50, that's an 80. If you got 40 out of 48, that's an 84. Okay? The other thing, keep in mind, if you did not do well, or did not do as well as you wanted, I am throwing out your lowest grade. Okay? So it behooves you to make sure this is your lowest grade. Okay? If you didn't do well on this test, make sure this is your lowest grade. Okay? perpendicular to the plane of another joint surface. Here's the plane, this is perpendicular, and the joint surface is moving perpendicular to that joint surface. What is that? Distraction or traction, right? It's moving perpendicular to the other joint surface. So it's not bad. We're asking about colliding. One point of contact on each surface remains in constant contact with a fixed location on the other surface. One point of contact and one point of contact. It remains in contact as motion occurs. So what does that sound like? Spin. Spin, right? Each subsequent point on one surface contacts a new point on the other surface. So the points of contact are changing on both surfaces. What's that sound like? Roll. That's roll. You're always coming in contact with a new point on each of those surfaces. That's roll. Okay? One joint surface moves parallel to the plane of the adjoining joint surface. Sliding. Okay? And a fair number of you got that wrong. I'm not sure whether it was the way you were reading it or just reasoning out. But that's how you want to look at these questions. And again, I go over this because these are the kind of questions you'll see on your licensing exam. So you really got to, often you got to go through a process of elimination. How come it's not that one? Okay? It could be that again, that you got a little confused about the perpendicular to the plane of the adjoining joint surface. That's traction or distraction. Okay? This is the one that a fair number got wrong, believe it or not. If excessive, this source of force may prevent joint motion. Choices are gravity, shortening of a single muscle, externally applied resistance, or friction. Is friction a force? Friction. Forces have magnitude and direction, right? Is friction a force? No. It's a characteristic of materials, of substances, of objects. It's not a force. Okay? Source of force may prevent joint motion. Shortening of a single muscle. Well, if a muscle shortens, motion's not prevented, motion's occurring, right? Motion is occurring. Okay? Gravity. Gravity? Do we have excessive gravity on the planet Earth? It's a constant, right? Is gravity going to stop motion? It may make motion difficult, right? It does affect motion, but is it going to stop motion? So the answer is externally applied resistance. If there's more resistance to the motion, to the force that's creating that motion, then that force can overcur, motion will be prevented. So it's externally applied resistance. Manual resistance, weight, pushing against an immovable object that's still pushing back against me, that's externally applied resistance, right? So that's why it's going to be externally applied resistance. This one I'm kind of surprised that somebody got it wrong. Inhibitory action at synapses results in what of the postsynaptic membrane? Okay, inhibitory action. Okay? What do we mean by inhibitory action? What does inhibition mean? Prevents or makes more difficult. It inhibits, right? It may prevent entirely, but it makes it more difficult in general. And the opposite is what? Facilitation. Makes things easier. Makes it more likely. Easier to occur. Inhibitory action synapses results in depolarization. No, that's when the polarity changes because of that nerve impulse depolarizing the cell membrane, right? Causing a nerve impulse. We have a switching polarity of the cell membrane. Repolarization, well, that's what occurs after depolarization. That's a return to that normal charge that charge relatively negative or relatively positive? Do you remember? Negative. It's negative, right. So there's a greater amount of positive ions outside the cell than inside the cell. Okay? And there's a relative distribution of those charges. Hypopolarization means the difference between those charges is reduced. There's not as many positive charges outside the cell relative to the inside. So they're closer to neutral polarity. Not that great of a difference between the charges. That would be hypopolarization. Do you think that would tend to make depolarization easier or harder? Doesn't take much of a change to cause that membrane to depolarize. Not a great difference in charges. That's hypopolarization. That's going to facilitate a change in polarity. It makes it easier. When there's a greater difference in charges, now we've got to have a lot more ion flow to cause that cell membrane to depolarize. That would be hyperpolarization. So that's going to inhibit a change in polarity of that cell membrane. It's important that you understand that one. Okay? So if a cell membrane is hyperpolarized, it's more difficult to depolarize it. So it's going to inhibit a nerve impulse. It's going to inhibit activity at that synapse. Okay? Yeah.
I guess, I put hyperpolarization.
Oh, I don't know if you got it right or wrong.
No, I put
Yeah,
hyper.
yeah.
So it's hyper is the correct answer?
Hyperpolarization.
Hyper is the correct answer. I put hyper. I'm thinking like when they're really close, it's already, I'm thinking like opposites, like so negative, a lot of negativity, a lot of positivity, and that's gonna lead to depolarization.
Well, remember, we're talking about the difference in charges inside and outside of the cell membrane. Okay? If it's hyperpolarized, there's a big difference in the charge distribution. If it's hypopolarized, there's not a big difference in charge. Less charge difference. Less electrical potential across that cell membrane. Okay, that's how you want to remember it. Okay, and this question is important because it relates to one of your true-false questions. From a physiological perspective, this type of muscle contraction is the most efficient, uses the least amount of energy. Okay, that's what we mean by efficiency in the context of this question. And your possible answers are concentric, isometric, eccentric, or isotonic. What's the answer? Uses the least amount of energy.
Eccentric.
How come? That's more important than knowing the answer. Why is that?
Because of its elastic properties.
Right, because you're relying on non-contractile structures to absorb that force. Do tendons consume a lot of energy? No, muscles do, right? In order for muscles to shorten or lengthen, in order for them to generate force, it has to use energy to do that. All those other options, concentric, isometric, and isotonic, primarily involve muscle activity, right? Where eccentric, we said, that type of muscle action or exercise uses the non-contractile elements of the muscle tendon unit to absorb force. And those tissues don't use energy. They're inert, right? They don't use a lot of energy. So the answer is eccentric. And again, that's going to relate to a question later on when you're true-false questions. It's asking basically the same question using different wording. So that energy efficiency of eccentric contraction is the key point. Not using a lot of muscle, or it uses some non-contractile tissue to absorb the force. With a biarticular muscle, right, multi-joint, two-joint component, if neither the proximal nor the distal end is fixed during a contraction of the respective muscle, what's going to happen? Neither joint is fixed. Your options are motion will occur at the proximal joint only, motion will occur at both the proximal and distal joints, no motion to move in a plane perpendicular to the earth, the effects of gravity are reduced, so a muscle weaker than 3/5 is able to move a segment. True or false? When a body part is positioned and supported to move in a plane perpendicular to the earth. Perpendicular to the earth. So the body part is positioned to move in this plane. Okay? The effects of gravity are reduced, so a muscle weaker than 3/5 is able to move a segment. True or false? False. If the body part is moving in a plane perpendicular to earth, it's moving against gravity, right? By definition, is a muscle greater than 3/5, is that muscle able to generate force against gravity? I'll give you that one. It should be 2/5. It should be 2/5. Okay? I'll give you that one. All right. It would have been better if we worded it a little bit differently. But yeah. So 3/5, yes, it's able to move against gravity. Muscles that are responsible for fine motor control exhibit small muscle to nerve fiber ratios. True or false? Muscles that are responsible for fine motor control exhibit small muscle to nerve fiber ratios. So a small number of muscles innervated by one nerve fiber. True or false? True. Right? So that nerve is controlling smaller amounts of muscle fiber as opposed to large amounts of muscle fiber would produce a great amount of force, more gross motor activity than fine motor. Golgi tendon organs are thought to provide information directly related to the position of a joint. True or false? False. False. What do the Golgi tendon organs provide information on? Muscle tension. Muscle tone. Right. Muscle tone. Muscle spindles provide accurate information to the nervous system related to muscle length. True or false? True. Okay. What stimulates the muscle spindle? What do we do to stimulate the muscle spindle and see how it responds? Stretch. Quick stretch, reflex, okay? Tendon reflex, deep tendon reflex, right? Do a quick stretch, the muscle spindle should resist that force, resist that stretch, yeah.
The previous question about the
Golgi tendon organs?
Can you repeat that question?
Golgi tendon organs are thought to provide information directly related to the position of a joint. True or false?
That's false, but what does? Is that the spindle or?
Well, that's a gross description of all the proprioceptive organs that relate to joint position, not specifically the Golgi tendon organ. Okay, that specific receptor. Okay. And this is the other one. If you've got the energy efficiency of the eccentric contraction, you should have gotten this one. For a given force, a greater number of motor units are recruited during an eccentric contraction when compared with a concentric contraction. True or false? Let me read it again. For a given force, a greater number of motor units are recruited during an eccentric contraction when compared with a concentric contraction. False. False. It's the same, that's why it uses less energy. We can absorb that force with non-contractile tissues. It's essentially the same question being asked in a different way. Okay? The question that I threw out was the question that asked about if insufficient, this force will create instability. Okay? And one of the possible answers was friction. And we already said friction's not a force. That question I threw out. Okay? You did not get, like we just threw out that question. So what I will do is, since really there was a incorrect mark of that one question, let me go back some of your grades may change another 2 points. I gotta go back and look. All right.
So the grade we see right now on Moodle, we have to add points to that.
You're gonna add 4 points to that grade. And then I've gotta go back and see, did you get marked wrong in the question you actually got right? I have to go back and look. Okay. All right? Yeah.
Is it okay if I ask you one of the questions?
I'm sorry?
Is it okay if I ask you one?
Sure, of course.
The angle of insertion of a muscle remains constant throughout the joint's range of motion.
The angle of insertion, okay, the angle is going to change. Where it inserts is constant. We don't change where that muscle inserts. But again, take the example of the elbow. As we go through a range, that angle of insertion does change. Okay, the angle of insertion. If I'm fully extended at the elbow, that angle is very low. As I begin to flex the elbow, that angle increases using the angle of the elbow flexion. Okay. So that angle does change as we go through a range. Okay, as motion occurs. Where it inserts obviously does not, but the angle of insertion does change. That's why we have different length tension relationships. That's why we're able to generate forces more easily at different angles, and why it's more difficult at other angles of the joint. Okay? Any other questions? Okay. All right, let's get into the shoulder. Again, we know,
Question.
yeah,
We're giving force a greater number of millimeters of, okay, never mind. Says rotating force. Never mind,
Right.
never mind.
Okay.
Eccentric, concentric.
right, right. Okay, first of all, as we remember, the shoulder's not a joint, right? It's comprised of joints. It's a complex, all right? So we're gonna accurately refer to the shoulder complex, not the shoulder joint. Because it's really comprised of 3 synovial joints, okay? And 1 pseudojoint. What's that pseudojoint? Scapulothoracic joint, right? Pseudojoint. Really, the whole purpose of the shoulder complex is to allow for a lot of mobility at that upper extremity, okay? As a general rule of thumb, and remember this for every other chapter, for every other thing that we do in this course and your thorax courses, we're always balancing mobility and stability to the best extent possible. If you have a lot of mobility, you're going to sacrifice stability. If you have a lot of stability, you're going to sacrifice mobility. Okay? That's a very simple rule of thumb. So we're always looking for the ideal balance between mobility and stability. And this is particularly true in the shoulder complex. Because we require a lot of mobility for normal function, but we're sacrificing the stability of those joints in order to get that mobility. And the primary purpose of this whole shoulder joint, shoulder complex is for positioning the hand for function. Whatever the function may be. Reaching, lifting, pushing, pulling, we're positioning the hand in the ideal position to perform that functional activity. Lifting, pulling, throwing, catching, whatever the case may be. So we're trying to get positioning distally and having that stability proximally, the grade stability proximally, to allow for that distal positioning. Again, it's that balancing act. If we start proximally, we can really identify the connection between our upper extremity and the trunk. How do we differentiate these 2 skeletal systems?
Axial and appendicular.
Appendicular and axial, right? So when we're connecting to our axial skeleton, we're really connecting at the manubrium through the clavicle. Manubrium is a portion of the sternum, right? It's the uppermost portion of the sternum. So technically, that's where we're really making that connection to the axial skeleton. Okay? And that connection is being made at the sternoclavicular joint. Okay? That's where we're seeing that clavicle attached to the sternum, specifically to the manubrium, the uppermost portion, superior aspect of the sternum. Okay? We also have a sternal or trochlear notch in the upper aspect mentioned on here, well, what's the distal most inferior portion of the sternum? Do you remember?
Cyclic process.
Xiphoid process. What's significant about that, other than it being the most distal aspect? What's one of the things that's notable about the xiphoid process that we need to keep in mind?
It's not made of bone, it's made of just cartilage.
Yeah, and there is a joint there, right? Right, that most distal aspect of that xiphoid process is attached to the inferior portion, of the distal, most inferior aspect of the sternum. And I don't know if you ever heard reference to this in your CPR classes. Okay, if we're performing chest compressions on an individual, which God forbid you ever have to, and we don't properly place our hands, we may fracture that xiphoid process. Okay, we may depress that xiphoid process into the thorax, into the chest cavity. Okay, so that's a bony landmark that's important for us to be aware of. Hopefully, we never have to. It never comes into play because we never have to do chest compressions on someone, but you never know. The clavicle, right, which is attached to the manubrium, articulates with the manubrium, is an S-shaped bone, looks similar to a crank, okay? At its sternal end, which is going to be the proximal end of the clavicle, it's tubular in shape, and then it's flattened as we move laterally and distally, right? As we go proximal to distal, we're going medial to lateral in this case. Same thing. It's flattened at its distal end, or most lateral end, to form the acromion. Okay? The scapula, we know, is a relatively flat and more or less triangular bone, all right, that has notable bony prominences, which we're going to look at and talk about. The vertebral border of that scapula covers a distance that runs from about T2 to T7. Okay, that's its normal orientation in the thoracic spine. It's where we get our attachments for the glenohumeral muscles, and it helps to provides a stable base, or it needs to provide a stable base, from which glenohumeral motion can occur. Okay? So if we're going to have a stable scapulothoracic joint, we're not going to get all of the necessary motion at the glenohumeral joint. Okay, two joints of the shoulder complex, one pseudojoint and one synovial joint. This is a concept that you also want to really keep in the front of your mind, again, for the remainder of this course, for your thorax, for all your clinical practice. Understand the relation, just like we talked about the relation between stability and mobility, this is the same thing, right? If we lose stability at the scapulothoracic joint, will we tend to get more or less mobility at the glenohumeral joint? If we lose stability,
More at the glenohumeral?
okay, we have an unstable scapulothoracic joint. Is that going to impact our motion at the glenohumeral joint? And if so, how will it impact our motion? Not what do we do to compensate, right? That's a different question, right? If we lose stability of the scapulothoracic joint, we're going to lose mobility at the glenohumeral joint, right? We will not have as much mobility at that glenohumeral joint because we can't stabilize the scapulothoracic joint. Then we may try to compensate for that, right? That's different. Okay, we may compensate by that by trying to get a greater amount of mobility at the glenohumeral joint. That's the compensation. Okay?
Does that have to do with the glenohumeral or the scapulohumeral rhythm?
Yes. Well, you're going to have an abnormal scapulohumeral rhythm, excuse me. Because we've lost stability, we're not going to get the same amount of motion. Okay? So we need, yes.
So, I mean, just in general, so like the scapulothoracic joint should be stable while like the glenohumeral
It
joint
needs to be stable so that we can have the normal glenohumeral motion. If we lose stability at that joint, we're going to lose mobility at the glenohumeral joint. Okay? They're related. Okay? Which is why when we're working with our quote-unquote shoulder patients, especially if we're talking about patients who have some involvement of the cuff muscles, stability of the scapulothoracic joint, the function of the scapulothoracic joint is so important to us restoring normal motion of the entire shoulder complex. Right? We can't ignore that scapulothoracic joint. And we're going to see we can't ignore all the individual joints that make up the shoulder complex if we're working on glenohumeral joint motion. Okay? And again, that movement of the scapula has to work in concert with the clavicle. Scapula attaches to the clavicle attaches to the manubrium in order to have total shoulder range of motion. If we have limited motion in any one of those joints, we're going to limit the overall shoulder range of motion. Any of the joints that make up the shoulder complex. If we have limited motion at those joints, if we're disrupting the arthrokinematics at those joints, we will lose total shoulder range of motion. Okay? And again, we know that the scapula, which again we just think of this kind of simple bone, it is anything but simple. These bony prominences are very significant and are implicated in a number of conditions that we see in our patients. Okay? Has superior and inferior angles. It has a spine, has medial-lateral borders. It has a glenoid fossa. It has an acromion. It has a coracoid process. Has attachments for the supraspinatus, infraspinatus, and subscapularis. They all attach via fossa on the scapula, fossae, or fossas. And it has a supraglenoid and infraglenoid tubercle, both tubercles. So these are important bony prominences for us to be familiar with that you could perhaps be asked about on a practical, for example. Okay? The glenoid fossa, we tend to spend a lot of attention to the glenoid fossa, appropriately so, because it provides the articular surface for a humeral head. Okay? But it's a pretty shallow and small fossa in comparison to the head of the humerus. And we try to deepen, and again, we're going to see this in other joints of the body. When we have a very shallow fossa, a shallow articular surface, the body deepens that fossa by adding something like a labrum, which is our cartilaginous structure, right? So the labrum helps deepen that glenoid fossa by about 50%, increases the depth of that fossa by about 50%. That glenoid fossa also is tilted slightly upward, about 5 degrees. When we look at that angle relative to the border, the vertebral border of the scapula. Slightly tilted, elevated, about 5 degrees. It's narrow at its uppermost portion and then widens as we go inferiorly so that we look at that glenoid fossa, it has more or less of a teardrop shape. Okay, it's not spherical and it's not oval, it has kind of a teardrop shape. It's also tilted slightly anterior, so it's got a slight upward tilt and a slight anterior tilt. Okay? So that's going to tell us that that humerus is going to be tilted slightly posteriorly, normally, if that glenoid fossa is tilted slightly anteriorly. Okay? When we talk about normal movement of the scapula, we know that that scapulothoracic joint, okay, is moving on the thorax, and it's moving in a particular plane because of the relative shapes of the thorax, the relative concave shape of the thorax, convex shape of the thorax, and the concave shape of the scapula. And as we move in that plane, we describe that angle or that motion as moving in the scapular plane, which is not straight in a sagittal plane. shaft of our glenohumeral joint, with the humerus, proximal humerus specifically, the head of the humerus is convex. Again, glenoid is concave. It forms about relatively 1/2 of a sphere at humeral head. Again, it faces medially, when we orient that humerus, it faces, the humeral head faces in medial direction, slightly posterior, superior direction, and slightly posterior. Again, we've got a slight anterior tilt of that glenoid fossa, so we've got a slight posterior tilt of that humeral head. Okay? It's angled in a frontal plane about 135 degrees, and in a transverse plane, it's retroverted about 30 degrees, 30 to 40 degrees. So these are the angles that we're talking about. This angle of inclination, all right? If we look at the shaft of the humerus and the orientation of the humeral head, it forms an angle of about 35 degrees, which we refer to as the angle of inclination. If we were looking, and when you look at your bones from a superior to inferior direction, we're looking down the shaft of the humerus here. We see there's a slight angle posteriorly of 30 to 40 degrees. Okay, oops, let me back that up. Okay, that's what we mean by retroverted. Okay, it's tilted posteriorly about 30 to 40 degrees. Yes?
This is relative to anatomical position, right?
All of this, well, if you just look at the bones, the bone itself, okay, this has nothing to do with anatomical position. This is looking at the morphology, the shape of the bone itself. Okay? The shape of the bone itself. You've got to differentiate anterior from posterior when you're looking at your bone from a superior to inferior direction. Okay? The humerus has several notable bony prominences. Again, they're notable because of specific attachments or structures that are associated with that bony prominence. Greater tuberosity, which has 3 facets, 3 specific facets that make up that greater tuberosity. A lesser tuberosity, an intertubercular groove, and the surgical neck. Okay? So this is our illustration. And we can specifically identify 3 specific facets on that greater tuberosity. I would not necessarily expect you to differentiate those facets if I were to point them out to you, but I would expect you to understand what attaches to the greater tuberosity. Okay? Our surgical neck. Anybody know why they use the term surgical neck and anatomical neck? Have you heard that term before? Know what it relates to? I see you shaking your head, Rodney.
Is it related to?
Yeah.
Go ahead. Is it related to when you like do surgery? Like
And why would surgery be done there?
shoulder replacement?
Perhaps, yeah, shoulder replacement, right?
That's where the fractures are.
Also where fractures occur most frequently, which is why surgery is going to be done there most frequently. So the anatomic neck really is going to refer to, if this is really the head, the neck is right next to the head, right? Don't we associate the neck being right next to the head? So this would be the anatomical neck, okay? That's why, from a pure anatomy perspective, we're going to refer to this as the anatomical neck. Surgical neck, because that's where most surgery will be done, either because we're doing a joint replacement or where fractures are most likely to occur. Does that mean you can't fracture the anatomical neck? No, of course you can. But that's why when you'll see that term surgical neck associated with many long bones. Okay. You're also seeing a deltoid tuberosity, right? You're seeing an intertubercular groove. What's associated with intertubercular groove?
Biceps tendon.
The biceps tendon?
The long head.
Thank you. The long head of the which tells you right off the bat, if you get asked a question, you be specific, right? You can never go wrong being too specific. You can never go wrong. So saying the medial aspect of the lateral epicondyle is better than saying the lateral epicondyle. And that sounds like a contradiction in terms. But you want to be as specific as you can be. Again, this is showing us on this greater tubercle these three facets that allow for three specific attachments of three specific muscles. Okay? But again, I wouldn't necessarily expect you, I wouldn't necessarily point out one specific facet because it can just be a little bit difficult to be that specific. Okay? Yeah.
So the supraspin is the most anterior of the three? Posterior view or?
You're looking at a posterior view, so you're looking, so if this is a posterior view, are we looking AP or PA?
PA.
PA, right, we're looking at PA, okay? So it's gonna be if you wanna say the most anterior, obviously you're better off saying it is certainly the most superior, right? If we look at the facet, it's the most superior. Technically, yes, it's more anterior because as we move superiorly, we've got a curve to the proximal end of the humerus, so we're moving a little more anteriorly as we move superiorly, but it's the most superior set. That's why it's named superior set, right? Okay? Good reason, okay? How many have heard the term shoulder girdle? I'm sure you have, right? Does the shoulder form a girdle? As you will find out when we look at the pelvis, no, it does not. The pelvis forms a girdle, girdle meaning encircling the entire trunk, the entire body. The shoulder does not. So that term shoulder girdle is a misnomer, right? I mention it because and I put it up in quotes because we hear it used all the time. We talk about shoulder girdle. Shoulder is not form a girdle. Okay? It's not encircle the entire trunk of the entire body, as a girdle will do. Okay? But that shoulder complex has several motions associated with it. Okay? And that is elevation, depression, protraction, retraction, upward and downward rotation, and scapular tilting, both medial lateral and anterior posterior. Okay? So we can differentiate, and again, these are movements of the entire shoulder girdle, shoulder complex, right? The sternoclavicular joint specifically, again, this is where we have our attachment to the axial skeleton. It is a saddle joint with 3 degrees of freedom. Every saddle joint has 3 degrees of freedom. Okay? And the motions that we see at the sternoclavicular joint are elevation, depression, protraction, retraction, and rotation. So those are the motions associated with the sternoclavicular joint. Okay? Do you remember what we talked about early in our course this semester when we talked about joint motions? That we can differentiate motions, joint motions, into 2 major categories. Do you remember what they are? Not direction of motion like elevation, depression, rotation, but type of motion. Do you remember?
Linear.
Well, linear or transitory, yeah, and that's related to motion and forces, but, okay, how about motions that we said we can perform voluntarily with contraction of muscles surrounding a joint is one type of motion. Physiological and accessory motion, right. So an accessory motion is a motion that you can't perform exclusively. So in other words, I can't only protract my clavicle. It's associated with movement at other joints. I can do it with an exterior force applied. Same thing with elevation and depression. I can't just depress my scapula, or my clavicle rather, isolated. osteokinematics is gonna relate to the movement of the entire bone, right? So you could say, yes, there's certain accessory motions that I can cause to occur of the bone only by applying an external force. I can't, and that would be an accessory motion. So it's physiological, and the other term that you'll see attached to that is anatomical motion. So your anatomy can cause this motion to occur. And if your muscle force, if your internal, intrinsic forces can't cause that to occur in isolation, then only an external force will cause that accessory motion to occur. Well, what's the most common external force that we use to cause accessory motion? Our muscular force, right? Not the individual's. And we use that muscular force during what type of treatment procedure? Don't overthink it. I want to cause accessory motion to occur in you.
Joint moves?
Joint mobilization, right. I'm going to apply muscular force to cause this accessory motion to occur. I'm going to try to, in isolation, depress the sternoclavicular joint. Can I do that with my muscle force, me, upon you? Yes, I can do that by performing a joint mobilization. Yeah, Lenny.
So, in regards to the sternoclavicular joint, would you say that the induced scapular protraction, the motion that the sternoclavicular does in regards to the protraction of scapula, is this an accessory motion?
It is accessory motion, and it's associated with the motion that's occurring at the glenohumeral joint, that's occurring at the scapulothoracic joint, and that's occurring at the acromioclavicular joint. Right? They're all associated. Okay? When we look just at that joint, remember, we say an accessory motion is something that you can't, in isolation, cause with your own muscle force. Some type of external force is going to have to be applied to cause that accessory motion to occur. Okay? Yes?
You were saying about osteokinematics, is that more associated with accessory or more physiological motion?
Both. Both. If we cause motion at a joint, is the bone itself going to move? It has to, right? They're attached. The articular surface of that bone is part of the bone, right? So yes, we're going to cause movement of the bone. If I apply a distraction force to your glenohumeral joint, is your humerus moving? Yes. Am I causing separation, distraction at the glenohumeral joint? Yes. The humerus has to move, unless I fracture it, right? It's got to move. But it's moving along with the force that I'm applying at that glenohumeral joint. Okay? Yeah.
From the first semester, the slide stated that a saddle joint was a biaxial joint. So is the SC joint just like a saddle joint with 3 degrees, or can they go back and forth? Or was that slide maybe just...
I'm not sure why it would say it's only got 2 degrees of motion.
Yeah, I was just looking at that.
Okay. Depends on which joint we're talking about. A saddle joint does have 3 degrees of motion. 3 planes of motion. 3 degrees of freedom. I'm sorry, not 3 degrees of motion. 3 degrees of freedom.
So are degrees of motion and degrees of freedom?
No, degrees of motion relates to if you take a goniometer, I can create 3 degrees of motion on that goniometer. 3 degrees of freedom means I'm moving in 3 different planes. I misspoke. Not 3 degrees of motion. 3 degrees of freedom. 3 degrees of freedom. Okay. If we look more closely at the sternoclavicular joint, there's actually a disc between the manubrium and the sternum, and the clavicle rather. surface of the disc and the other surface of the disc. And actually, that disc serves as kind of a hinge for all these motions. That's one of the things that makes this joint different than some other saddle joints that do not have an articular disc, intra-articular disc. Okay? And what type of tissue do you think that disc is made of? Cartilaginous tissue. And what's significant about that? What's one of the things that we know about cartilage? Like cartilage within the knee, which we
Like a
refer to.
shock absorber?
It's a shock absorber, right? Can cartilage be relatively easily injured, damaged? Definitely. Okay. Can you have a cartilage tear in the knee? Yeah, it happens fairly frequently, right? Meniscal tears? Yes, we could have, and specifically fibrocartilage, right? It's not hyaline cartilage, it's fibrocartilage. So cartilage is subject to damage, subject to tearing. So conceivably, we could have a disc tear, a cartilage tear at the sternoclavicular joint. Is that going to affect motion at the sternoclavicular joint? Is that going to affect motion at the acromioclavicular joint? Is that going to affect motion at the scapula? So yes, yes, and yes, right? All right. So again, this complex is getting more complex as we look at it more closely, right? In addition to the volume prominences, in addition to the presence of an intra-articular disc in the SC joint, there are some specific ligaments that are notable. Anterior and posterior ligaments, the interclavicular ligament, and the costoclavicular ligament, which attaches the clavicle to the first rib. Okay? Do you remember, I suspect you probably talked about it, do you remember a condition that can be associated with this costoclavicular ligament? Thoracic outlet, right. And in the surgical treatment for thoracic outlet, they may sever and remove the costoclavicular ligament, may even remove the first rib. Okay? This happened to a couple pitchers that you may have heard of, like Matt Harvey. So yeah, there's some specific ligaments that are associated with the sternoclavicular joint. In general, this is an extremely stable joint, the sternoclavicular joint. Okay, these ligaments are very short and very strong. Generally speaking, shorter ligaments are more resistant to damage than longer ligaments. Shorter ligaments, why do you think that might be? Now we've got to think back to the beginning, our beginning chapters here. Like force arms, resistance arms, right? Short ligaments probably have a shorter force arm working upon them, so they're less prone to damage. Longer ligaments are likely associated with longer force arms that can make them more prone to damage. How about a longer ligament that we often see injured in our patients? ACL, MCL, LCL. Long ligaments, long lever arms, long force arms acting on a relatively long ligament. Yeah, Chris?
Could you say that like a longer ligament is going to help provide more mobility, a shorter ligament more
Exactly, exactly. Short ligaments promote stability. Longer ligaments help to promote mobility. But again, we're back to that same rule of thumb. More mobility, less stability. Okay? More stability, less mobility. So there's not a lot of movement at the sternoclavicular joint. But movement has to occur in order for that shoulder complex motion to be normal. Okay? Yeah?
I'm sorry, can you explain again about the force arm?
If you've got a very short ligament, okay, and you've got a very long force arm, okay, that ligament is able to absorb a lot more force. It's in mind is, again, shorter ligaments are going to you're going to associate with greater amounts of stability at that joint where those ligaments are attached, but not a lot of mobility at that joint. Okay? So if you look at osteokinematics of the SC joint, movement of the entire bone, in the frontal plane, moving in an AP axis, we've got 30 to 45 degrees of elevation, okay, of the clavicle on the manubrium, okay, and those muscles are primarily the costoclavicular and subclavius muscles, okay. You got about 5 to 10 degrees of depression, so there's greater amount of elevation of the clavicle than there is depression, okay. And in the transverse plane, along the superior-inferior axis, is about 15 to 30 degrees of protraction and about 15 to 30 degrees of retraction. This is of the clavicle on the manubrium. If we look at rotation, we're looking at that long axis of that clavicle, that crank. So this is motion that's occurring in a medial-lateral axis. There's a posterior rotation of the clavicle with shoulder elevation. Clavicle tends to rotate posteriorly with shoulder elevation. Okay? And that occurs in about the second 90 degrees of shoulder elevation. Okay, that's where we see that rotation occur. Not in the beginning of the shoulder elevation. And elevation simply moves to not just flexion or abduction. Elevation of the shoulder could be a combination motion. Bring the shoulder above 90 degrees. Bring the humerus above 90 degrees. Okay? If we look at the arthrokinematics of the sternoclavicular joint, when we have that elevation and depression motion occurring, the osteokinematics of elevation and depression, we've got a convex surface moving on a concave. What, in this case, what's convex and what's concave? The convex surface of that proximal clavicle and the disc itself has more of a concave shape to it, that intra-articular disc between the clavicle and the manubrium. Remember, we've got movement between both surfaces. But we're looking primarily here at the proximal medial end of the clavicle. When you look at your bones, that's why when you're looking at your bones in lab, don't just pick them up and look at them. Really look at your joint surfaces, the articular surfaces of these bones. As I've said to you before, one of the main goals in this class and in this course is for you to get really intimately familiar with the articular surfaces of these bones. You don't want to try to memorize this stuff. It will make sense to you if you get a good mental image of these articular surfaces. Not just the bony attachments of ligaments and muscles, but the articular surfaces themselves. It's going to help you with a lot of your questions. Okay? So elevation and depression, we've got a convex moving on a concave. Remember, this is a saddle joint. It's got different shapes and different orientations. In protraction and retraction, you've got a concave surface moving on a convex surface. And in rotation, it's really the clavicle just spinning on that articular disc. Okay, that's the posterior and anterior rotation that we see. Okay. Let's see, I'm going to quit right there, and we'll pick it up at the AC joint. Okay. Any questions? Just so you know, once I go back and take a look at that one question that I got to make sure that it was not marked incorrectly, you got it correct, I will notify each of you of what your final grade was on this exam, so that you're aware. Again, you can add 4 points to what you're seeing if you took it. I know a couple of you did not take it downstairs.
Some people come checking out and they like,
You know, where are you in the property? Like, how many acres you have?
45. So, at the beginning, so it's called like a square for all intents and purposes. Right at the beginning is like where we have like the trailer house, and then we have a road going up, and then a road here, and then another road going all the way to the top. It's like in a mountain.
Yeah.
It's by like half an hour from Monticello.
Okay.
Right at a good truck. But typically we have a trailer for the quad, and so we'll put in the trailer because it's just least chance of it flying out. So, $100
Then you would see like people driving down the turnpike with
turnpike
like
or throughway,
the throughway, like deer, like hooked to their front,
A grill.
yeah.
Or on the roof tracks of a Subaru with the top over just hanging out.
Oh, I've seen that. I've seen that. Like the blood,
It makes
the
us
blood
look
over
really
the
bad.
water.
It makes us like really like humane hunters look really bad.
no stress.
But, so we pay $100 to get a butcher to get like 60 pounds of meat. Like 50 pounds worth of beef is like 3 or 4 times that. Like money wise. So like you save so much money. That's why I do it. Really.
Hey, Professor,
Yeah.
Yes, and chicken.
I have a little story for you,
Oh yeah.
inpatient story.
Okay.
So I go in, I told my CI I hate inpatient and I don't feel comfortable in it. So he kind of forced me to like, alright, like, you take the reins, like, you do most of the work. So, we go out through the whole day, pretty good, nothing happens. He's like, no, it's not that bad. It's like, oh, true, we have to go up, we have to go see this one patient. Most we've been able to do is get her sitting bedside, and she only speaks Spanish. So you speak Spanish, it's all you, man. Go in the room, gear up, whatever. I asked this freaking lady how she's doing. Okay, cool. She's fine. She just says she's a little dizzy, disoriented at times, and she's like a little tired. But she thinks PT will do well for her because she's just been laying in bed. Okay, cool. So here I am, trying to be like proactive and just, right? Because he told me, he's like, I'm not gonna help you, you do what you think is best. Okay, cool. So ma'am, I'm gonna just get you over to the side of the bed and we're gonna go for a little walk, right? Let's see how far you can walk today. She just ignores me, okay? So I grab the walker, put it by his bed, and I'm like, we're gonna go for a walk. And she again ignores me. And then the last time, I'm like, excuse me, is it okay if we go for a walk? And like, this is in Spanish. So my CI's like, alright, he said caminar. Like, he could have stopped me after the first time. But he was just like giggling, and like, I didn't even see him. Man, why is he ignoring me? And then he walks over and he's like, hey, Steve. He takes the covers off. And he's like, yeah, she has no. She's not gonna know.
Steve! Did you forget to read the chart?
So,
Yeah, Yeah, but that's kind of mean for him to do to her. Here, my God.
So he's very much like, don't treat the symptom, or like, it's not a knee patient or shoulder patient, just like, treat the person. Yeah.
Oh, sorry.
She said,
I asked the bloodless patient to go for a walk.
Steve, I'd never do it again.
My RCI comes over and looks covered.
Patient non-compliance.
refuse PT.
Refuse PT due to bilateral. Ask patient to walk, she refused vehemently.
Yeah.
All right. So we're gonna finish off with last week with CBA, and then we'll get into the actual rehab of it. So just to finish off, we're gonna start with the Flexor Synergy test Monday, review Friday. Yes.
What time is the test gonna be?
What time?
Yeah, are we still gonna have lab?
Yeah,
Yeah.
on Monday.
Yeah.
Yes. Oh, I see what you're saying. You get the test before and afterwards. Yeah, we'll do it, I see what you're saying. All right. Now,
Wait, we have two.
we'll have to figure that out. Just one, like no kinesiology, I think, correct?
No test that day. We have pasta.
Yeah. Yeah, well, I guess we'll have to do it in here. I'm gonna try to get it online though, so bring your tablets, bring your stuff.
So it's gonna be at 1, right? Not 1:30?
1 o'clock. Yeah, you will come.
Or can we do the
No, because you have kinesiology lab. That's part of the problem, is the kinesiology.
Just verify, you said motor control. and
It's
motor
not on it.
development,
All right, so just to recap, the test was, your first test, so we're going to cover the neuroanatomy. So certainly obviously your lobes, your spinal tracts, your dermatomes, your myotomes, your blood supply, your reflexes. The motor control and motor development will not be on there. So it's first day. The pediatric conditions will be on there. So primarily you're going to see a lot of CP, but CP, osteogenesis imperfecta, the Duchenne's muscular dystrophy, myelomeningocele, spina bifida. You'll see some questions there. But I can tell you a little, little clue. If you understand your, say, myotomes, some of the spina bifida questions can be easy. And that's why I reiterate, you know the anatomy. Everything ties back to the anatomy. Okay? Then after, so that's the pediatric stuff. Then for the CBA, PNF. So for PNF, know what occurs at the joint. And again, just focus on glenohumeral, scapulothoracic, and hip and pelvis. So what motions occur with D1 flexion, D1 extension, D2 flexion. And the definitions. The contract relax, alternating isometrics, resistant progression, like those definitions. But you'll have to, again, you'll see it, you'll see a clinical scenario and sort of, okay, this, the PTA is performing this, which of the following PNF technique would that consist of? Something with gait, resistant progression, alternating isometrics, blah, blah, blah. And then the CBA will cover the, your syndromes, anterior cerebral artery, middle cerebral artery, know that. We're going to get into the synergy today, so know what occurs at the synergy. And then later on, when we do the rehab, we'll get into the Brunstrom theories, and I'll point that out there. All right?
What about neuroassessment?
Well, that goes with, say, the cranial nerves. Like I might ask, which of the following would be the best technique to assess cranial nerve 6? So you have to know what the cranial nerve 6 is, and then obviously what it does. So that's how it's going to be applied clinically. But it's still just the basic understanding of specifically, the nerves and the anatomy, the neural anatomy. All right? But again, I'll give you guys a review Friday. Today's Wednesday. So on Friday before we do elbow, we'll do a review for neuro. Then you study all weekend. Over 100. Study.
Not birthday.
You go up in, happy birthday. You go up in like the,
Yeah. Yeah.
So I had a patient a couple years ago.
It fall.
Yeah.
How was it?
C5 level. Yeah.
Wow. How are harness?
Oh, okay, good. So there is safety stuff.
Oh, absolutely.
All right, so we talked about, again, CBA going back, right? You have your different syndromes depending on which artery was occluded. Primarily, middle cerebral artery is what you're going to see. I would say if you see a question where it says, what the patient presents with these symptoms, which artery would be occluded, like you can say like a good guess would be middle cerebral. That's where most of the strokes occur. But for the sake of not giving you, it's not going to be, it's always going to be something else. Because I wouldn't do that to you, it's too easy. Because we have to study.
So the answer
So the answer is never middle cerebral artery for me. It's too easy. All right, so synergies. These are, again, underlying patterns that develop with reflexive behaviors following some type of neurological insult. So it's the deep centers of the brain. It loses that inhibitory technique. So there are stereotypical patterns, and usually these patterns will emerge with some type of stress. So your patient with the stroke can just be sitting there, but if you ask them to reach for something, that's when you're going to see those patterns. When they start to walk, that's when you'll see those synergies. I don't know if you guys have seen it out there. Anybody work with CVA patients? So you see, but again, they can stand there, and then when you ask them to move, that stress, that's when they will perform that synergy. That's when you see the synergy will emerge. And later on, when we talk about the rehab part of it, if you're using the synergy for function, that's a good thing. They perform this to feed themselves, well, that's a good thing, right? If our goal is to get independent feeding, well, let's use that synergy pattern. Well, depending on what class you take. So at the scapula, you have elevation, retraction. Shoulder, abduction, interrotation. Some books have external rotation. This came from your book, so that's why I use it. But I've seen external rotation out there.
Yeah.
Where's your Giles book?
My slide says external rotation.
Oh, so you got, you know what?
Is it external?
You got, it's external. So you got, you know what, I was looking up on the book. So this is probably the older PowerPoint. I sent you guys a newer one. So it should be external rotation, that's correct. The shoulder is abduction, external rotation. For the synergy. Yes. Elbow flexion, forearm supination, wrist flexion, finger flexion, and abduction, thumb flexion, abduction. So that's the position. So, again, depending on what your treatment philosophy is, we learned last year for positioning, we want to position out of that, correct? But again, if that synergy is used for function, we don't want to break that. So that's where it becomes difficult to figure out, well, do I want to break the synergy? Do I want to use it towards function? And that's the hardest part to assess. What we also learned is that a lot of times after a stroke, patients start flaccid, and then they develop that synergy about 2 weeks afterwards. So whether you use that synergy, again, as part of the treatment to help with function, again, depending on what you guys read out there, if there's certain classes you take after you're done, you have your license, again, up to you guys to determine that, because there's multiple philosophies. For the lower extremity, hip, abduction, lateral rotation, knee goes into flexion, ankle dorsiflexion, supination, and toe is into extension. 90% are going to be flexor synergies. You will see that there are extensor synergies, about 10%. I've never seen one yet. But yeah, primarily you're gonna see flexion for the upper extremity and lower. For extensor synergy, scapula is gonna be depression, protraction, shoulder, medial rotation, adduction, extension of the elbow, pronation of the forearm, and then extension of the wrist with flexion of the fingers. For lower extremity, we're getting extension, medial rotation, adduction of the hip, extension of the knee, plantar flexion, inversion at the ankle, and then flexion, adduction at the toes. If anybody sees one, let me know. So we discussed that. So again, that's your, so going back for your synergy, just know what occurs at the joint when you guys are studying. Then, getting into the treatment part of it. All right. So recovery prognosis, most of our gains are going to be early on, except that we can get some gains up to a year. So, but most important part of the rehab, where you can be aggressive, is going to be the first few stages, the first few months of rehab, starting with inpatient hospitalization, and then progressing to, obviously, the subacute center, and then hopefully outpatient after that. So fastest in the first few weeks, measure recovery usually within that first month. What you're getting is, hopefully through the medical management, reduction of edema on the brain, return of oxygen and blood supply, to the brain. So when you really think about the study of, neurology, it's very infant. It's, very, they've been looking at the body for many years, but a lot of study towards neurology and neuroanatomy is really in its infancy in terms of what we know and what we're learning, on a daily basis. So one of the things that we're hoping to do is sort of remap. Once they get healed, blood supply is submitted, they get the blood supply back, they get the oxygen back. We're looking to remap the brain, sort of get those nerves to fire and sort of get that signal, the synapse sent back down to the muscle. And so what you see is a lot of the repetitiveness, a lot of repetitive treatments and looking to get everything firing again. And so that's why a lot of times with stroke patients, we don't know what the outcome is going to be. And you're always looking to, you want to teach them, well, this is what might happen, these are the results of your stroke, but certainly our goal is going to be to, get you walking again. We're going to keep working hard to get you walking again. So after they reduce the edema, absorption of that blood, you're getting sort of new collateral arteries sent to the brain, trying to get it to heal, to get refired, really work those synapses again. But functional gains occur within the month and even up to years. So don't give up. So improving oxygen, whether it's with the nasal cannula, with medication, blood thinners, most likely they're going to be on, and then our concern about somebody on blood thinners will be excessive bleeding. So things we want to notice if you're looking at a chart, what the hemoglobin is, if there's any bruising or bleeding anywhere, so you want to keep up with that. You want to look at other stuff as well in your chart. You're looking to maintain their adequate blood pressure through medication. When you guys have gotten into your clients, like with your CI, mainly those that read charts, do you guys ever do a medication review? You did, yeah.
And especially hemoglobin.
So I'm sure there's standard. We're going to get into this next year, but there's like standard blood, like a blood analysis that you're going to look at. Hemoglobin's going to be one. Your hematocrit, your white blood counts, right? Those are things that are pretty standard in the hospital. That when you go and you do a chart review, because that can change on a daily basis. So, again, with the hemoglobin, if somebody's anemic, and we're gonna get into that certain levels, you're not gonna want to perform therapy, they're gonna be too weak. I had a patient just yesterday in North Arlington. He was COPD and heart failure. So I've seen him for a couple weeks, and we were walking, he was doing real well. Pushing him, he got tired with it. I go in to see him yesterday, and he's slurring his words, can't even speak. We're gonna get into, well, we did obtunded. You guys remember the definition of obtunded? And that's gonna be on the test too, not obtunded. But those alertness, so alertness, orientation, going back to those, that's gonna be on the test as well. So obtunded, anybody remember what obtunded means?
Semi-coma?
Still not semi-coma, but
Very difficult to.
you can, right, they wake up on some type of stress, but then they fall right back to sleep. So that's what this patient was yesterday. So call 911, ended up just retaining, so he was back in heart failure, retaining a lot of fluid, not urinating. So obviously, whether it was also on top of like some respiratory distress, but again, you're looking at that patient, you're seeing every day, what is the change? If that patient has cognitive issues and they're like that all the time, you know that's, I don't want to say normal, but you know that's the way they are. And so you're always assessing. So same thing with our cardiac patients or stroke patients, we're going to look at those values. So I bring up blood pressure because a lot of our patients have a family doctor, they have a cardiologist, then they go into these nursing homes, and that doctor who's associated with that rehab center has no conversation, no connection to the outside doctor. They put them on other medication that they're comfortable with. They get sent home, and they're on 5, 6 blood pressure medications. You go in, you're treating them, and their blood pressure is 100/60, they're really tired, but yet you look at their blood pressure medication, they're taking multiple medications. So one of the big causes of hospitalization is over-medication or medication use, and the other one is falls. Well, if somebody is severely medicated and lethargic because of that, they have a greater tendency to fall. So don't question about the medication taking. Just do a medication review and see. And if they're on multiple medications, I don't expect you to know what each action is, or what the side effects are, or what the interactions are. When you have your phone, you go on drugs.com, that has all that stuff there, so you can certainly use that. I don't know if you guys have done that out in the clinic. We had old books back in the day. You guys can certainly use your phone and see what the interactions are of those drugs. So again, a lot of multiple medications you want to really see. Talk to the therapist. Hey, I noticed he's on 5 blood pressure medications. 3 of them are the same exact type. Well, maybe you could be instrumental in changing that, because the patient doesn't understand that. They just think whatever the doctor says is the gold standard. We've got to listen to our doctor. So again, keeping hydrated, electrolyte, maintain bowel and bladder, catheter, if you're involved in that, maintaining skin integrity, any type of anticoagulant, and antiplatelet, which is aspirin. Although a study just came out,
Yeah, I saw that.
Professor Carpenter, you see that? No longer do you take aspirin.
I saw that.
No more. How many years were we telling patients take aspirin? Now we don't take it anymore.
Yeah, they said it thins it too much.
It
It's
did,
too
yeah.
much. Yeah.
Too much what?
It thins your blood way
It
too
too much.
much.
Too much.
Yeah.
So tell you, no more aspirin for you guys. Baby aspirin a day was good to prevent heart attacks. No more. Save your money. All right. So early on in rehab, early mobilization, prevent deconditioning, secondary pain, and impairments. Early stimulation, right? Get that sound side used. We talked about the mirror therapy, use the mirror. Get them aware of what happened. Teach them what happened. Educate them on what the symptoms of the stroke, but also on the recovery. All right, so early mobilization using the hemiparetic side. Okay. Through that neglect, they can develop as learned non-use. where they know it's there, just easier not to use it. You develop these habits. And you've seen it so many times because they've been so much using their non-involved side, even if they have strength and use of the involved side, they don't use it. So force them to use it. We'll talk at the very end of the slide is constraint-induced therapy, where you actually tie somebody down, like you tie the arm down. It's very effective. But whether or not you can use it, again, different story. Keep that positive outlook. Depression, apathy, very common, right? So try to maintain that upbeat persona. Tell them, yeah, you'll get some function back if you believe they can, and you're gonna work very hard to get them functional again. Work on the goals, reasonable goals, include the patient in that plan of care. And work with family and that interdisciplinary team. But early on, you also gotta be careful for any type of medical emergency. Right, so you're always going to monitor vital signs, right? Heart rate, BP. Look if there's a secondary TIA. All right. Question.
Yeah, does hemianopsia include the neglect, or is it just the fields of vision?
It's just the fields of vision, and neglect is different.
Is that its own, like, is that the term you would just say, right or left side of neglect?
Yeah. Yes. All right, so in post-acute inpatient rehab, that multifamily, multidisciplinary team, again, working towards the goals, looking to improve strength, flexibility, balance, endurance. All right, so functional, bed mobility, transfers, but you also want to integrate some socialization, so social, recreational skills, and make it enjoyable for them. Bedside care, diaphragmatic breathing, deep breathing, especially if they have paralysis on one side. You know, we always see, whether it's the upper extremity, lower extremity, we always see the extremities. We don't see the weakness, the paralysis of the trunk muscles, of the part of the diaphragm, the intercostals. So if those muscles are weak and paralyzed, that's going to affect their breathing. So diaphragmatic breathing, very important early on. Positioning, promote scapula and protraction. Again, avoiding those synergistic movements if it's going to affect function. Some type of splint or a towel in the hand. What separates us from every other mammal, right? Yeah, the opposing thumb. We want to make sure we don't get stuck in that flexed pattern, because then again, it takes away our fine motor skills. So positioning is very important. Limit the number of pillows under the patient's head. I know we talked about this with the pediatric stuff. Why am I limiting pillows under their head? This will be on the test.
Go ahead. You don't want them to have a flexion?
No flexion contracture. Nope, nothing to do with the artery. Well, that puts me in bad line, but why? Why? Why do I want to avoid flexing?
Vision?
Nope. Get closer.
Anything to do with like breathing or something?
No, not breathing.
Occlusion of arteries.
No. So it's not occlusion of arteries, it's not breathing, it's not vision.
Because it's contracting.
What are we talking about? Especially early on, again. Nope, no contractures. Oh, I said it a few times at the very beginning.
Last year?
When we talk about, okay, you had to keep, no, I'm the wise guy. A sick crowbar on you. So what do we talk about with our neurological patients? What reemerges? Oh, you remember now? Remember this conversation? How many times I told you?
Unfortunately, no for you.
So what happens if I have too many pillows under the head and they're flexed? What is going to occur? And I sent you guys I typed up a separate piece of paper just for you guys to go for this. What happens if I flex my neck?
Start going
What's that called?
Fetal?
Physiological effect.
Fetal
God.
position?
What is that called?
The fetal position?
Mono reflexes?
Yes, what reflex is that?
Mono?
No.
No, is it, oh my God.
That's
Oh my
Moral,
God.
moral.
No, it's not the Moro. No, it's not the Moro reflex. Oh my God, you guys are terrible.
Symmetrical?
So make sure this weekend, go back and study your reflexes. STNR, thank you. How hard was that?
Really hard.
Well, I told you guys, you had pediatrics last year. Your reflexes are very important for neurology for our adult patients because they reemerge. We can use those reflexes to help us with treatment, or those reflexes can hinder treatment. So for our neurological patients, for our CVA, which we're covering today, next week we'll get into TBI, and then we'll get into brain, spinal cord, where our reflexes are still going to affect that. We need to go back and relearn our developmental, our sort of primitive reflexes. So I don't put extra pillows under their head because that's going to affect the STNR. Nor do I put any pressure on their feet. Why not?
Binsky?
Oh my God! You stink!
Huh?
I'm embarrassed here.
That's what he said. He said pressure on the
Evaluated
foot.
for promotion, and she's gonna write. This guy doesn't teach anything. His students are horrible. They don't remember a thing. Plantar reflex. Thank you.
Is there gonna be extra credit?
No, it's gonna be sick. I'm gonna give like the test on. I think it's 60 questions. I think like 58 are gonna be reflexes.
You didn't teach us though, it was,
Right, Professor Wallace, but I.
That's not your bad.
All right, thank you.
Yeah.
He's good, he's good.
All right, so back to it. So breathing. So again, so what becomes important then is positioning. We want to position our patients in a, I want to say neutral position because that's going to prevent the reemergence of those reflexes. All right, special consideration, encourage patients to acknowledge their involved side. Use the mirror. Hey, tell them, hey, you still have it, we can still use it. Leave commonly used objects in the visual field and avoid hand squeezing exercise and the use of footboards. Brian, why do we do that?
Babinski?
So early mobility. So our goals towards walking, bridging. We did this the other day in lab before our lab got relocated. The approximation, push down. Anything affected you guys upstairs?
Just a big long crack.
You had a big crack in the wall? Wow.
Is that nursing?
Radiography.
Oh, wait,
I read about that.
get a car on the other side of the wall
And just push back. So bridging approximation, straight leg raise, both involved, uninvolved leg, hip and knee flexion. Again, the hip and knee flexion can prevent extensor synergies. Trunk rotation, double arm elevation. So early exercises to do. Rolling, double arm lift. Right, so the PNF chop pattern. That'll help with bed mobility. Scooting, supine to sit to stand, transfers. So those exercises to help with function. Work on balance and short sitting. And then balance and postural control and short sitting. Perturbations, the PNF type stuff with the alternating isometrics. Right? So start to develop that proximal control with the goal of eventually, walking and moving. Preambulation, work on your weight shifting. Approximation of the involved extremity with the weight shift, so I can work on my weight shift and reach, right? What's that?
Rotation.
Right, some rotation, right? To get back that reciprocal pattern, so I can break down sort of that gait pattern. And I mentioned the different types of functions, sit to stand, and even the weight shifting. So remember, exercise-wise, you have a patient with the stroke and the goal. The plan of care includes gait training. Just remember, we got to crawl before we can run. So we start with our supine, prone positions, work on the bridging, work on that proximal strength. sit them upright, work on the strength, balance, posture control there, and then eventually progress to standing exercises. Get them used to gravity, get them used to upright, and then work on weight shifting from there. So gait training and parallel bars, stepping forward with the uninvolved. Maybe I'm there to provide that cue, right? My right side's involved, I'm there to facilitate and just have them hold on, bring the leg forward and back, provide the facilitation at the pelvis to get that rotation, at the hip to get hip flexion. Work on the involved side as well, both uninvolved and involved. By me moving the involved forward, so again, if my right's involved, by just stepping forward with my good leg, what's happening with the involved one? I'm putting weight on it, right? I'm also getting that rotation back, right? So that the pelvis is moving in the three planes it needs to move in, right? So also incorporate the good side as well. Advancing the pelvis, I can progress to side stepping. And again, the facilitation for these patients will be important as well. So again, part of your treatment, just as this would be the strengthening, but work on the gait training. Break down the movement and get the pelvis to move forward, get the hip to flex as they're walking, just using the parallel bars. So again, strategies to improve motor function, positioning them out of the synergy efforts.
You want to be on the involved side.
I'd be on the involved side.
So yeah, I mean, that seems like common sense to me, and I'm not going to name any names, but I had a therapist basically who was saying like, all right, so when you have your assistive device, you're going to have it on your strong side, right? And so he's saying that you would want to have it be where you would have the assistive device on the strong side. I'm like, I don't know
I
about
do this
that.
literally every day at the neuro rehab institute. It's wrong.
It was the opposite.
Yeah, okay. All right, just, you know.
If I were to guard someone
Yeah.
on their assisted device side and they had a loss of balance to the opposite side, to their affected side, I would be SOS.
Let's say they didn't have an assistive device.
What is that?
With no assisted device, you're guarding on the weak side.
You're still on the weak side,
Still on the weak side.
either way.
Yeah.
So if I have the
So,
cane,
without assisted devices, I still always guard and I still always on the affected side.
yeah,
Okay.
yeah, always. Because even if I have the cane, well, that cane is just increase that basic support. They're going to go, and the cane should be on the opposite to the involved side. So they're still always going to go toward that involved side.
That way,
If they have a
when
walker-
they actually do lose their balance to the involved side, you're on it, you can pull them into you and catch them, or you actually have the ability, since you're right behind them, and I use a gate belt all the time, to kind of, just lock out my arm, guard the shoulder, and keep them from losing that balance. Like a Made or something.
Even a walker, you're still going to be on the involved side.
Yeah.
Makes sense.
If you can. You know what I mean? If you have a narrow hallway, well, things change.
Or if like, the room is set up in
Yeah.
such a weird way.
You still, either way, your hands are on them.
Even
It's
when
not always, you're not always going to come across, it's never going to be the perfect world. It's never going to be what we had here in labs, right?
Yeah, like when I'm doing it at the clinic and I'm ambulating a patient through like a really narrow doorway, or there are other patients in wheelchairs around, the only thing I'll do is I'll step posterior to them and then right back to
Yeah.
posterior lateral.
Yeah.
Usually like posterior.
As long as you're always on.
Yeah.
And again, we taught you guys to use a gate belt. I know clinics that will not allow the use of a gate belt.
Why?
Why? Because they think they rely on the gate belt too much to hold them up instead of your actual, like both hands. Yeah, they don't, there's places out there that don't use gate belts. I also wonder if it's liability too. I'm wondering if it's also liability that, with the gate belt, that you hold on. I'll have to find out. I'll ask.
Ambulate through that doorway through the frame and then I would step back to the
That's like the whole, because you're
Yeah.
basically attached to something.
Yeah.
No, because they have the device, that device is there so they have that support on their strong side. They have like that basic support now shifted so it's much wider.
Yeah, we learned that, Professor Doyle told you last year. So you're always going to guard the involved side, the weaker side. Because that's where they're going to tend to fall to. All right, so with position, so use gravity, use positioning to help. And if you want to break down the synergy, position them properly, we did that last year. We can use splinting, we can use, and we have it in the lab, where, and if they have flaccidity, you guys ever see like the tubes? You can put the hand to the tube, you blow it up, so it acts as a splint. So I can do function with that instead of having to worry about flaccid arm. So you can use stuff like that. Moving on, you can do different types of arm cradling. So use the involved, cradle the involved with the uninvolved. Sort of like an active assisted range of motion, active assisted movement. Make sure you incorporate that. Tabletop polishing, sitting, leaning, push their base of support, or push their center of gravity towards their base of support, working on balance, working on trunk control, and then also stability. Lower extremity range of motion, plantar grade to stretch, plantar flexes. Again, this is any type of strengthening that's going to start proximal, progress distally, working towards function. So again, positioning strategies, we want to make sure everything's midline. So if they sit in a wheelchair, we don't want them to lean to one side. Use like a block. You can add a lot of stuff to these wheelchairs, which we'll get into it on the semester, but use a block to keep them upright. Use some type of head control, head support to keep their head in midline. STNR, ATNR to avoid those. So with the head and neck, you want to keep it neutral, symmetrical, keeping the trunk aligned to midline, keeping the scapula. If they have some extensor synergies, if I have them flexed above 90 degrees at the hip, that's going to break that synergy. So you guys are going to be involved with, again, setting up the wheelchair and what can we use to help this patient with the wheelchair. Whether it's a lap tray, if they're very weak, whether it's a lap tray to help keep them upright. So we can certainly use that. Again, it depends on what your facility thinks about restraints. Sideline, you want to keep the head, neck neutral as well. Trunk is midline. Scapula protracted, forward, elbow extended, something in the hand, again, help with the functional pattern. You can also sideline on the hemiparetic side, same position, sideline, keep the shoulder protracted, elbow extended. Sitting in an armchair or a wheelchair, head and neck is neutral. Trunk, keep it upright, and use pillows, bolsters to keep it upright. You want to get equal weight bearing on both sides.
So to hit on that head neck positioning, so we have a patient that had 2 CVAs back to back within a week, and
One side.
yeah, one side, same side, and so it's her left side that's affected, and her right side is now developing a contracture, and so she's now in this position. And so how would you properly position her, because they've tried everything and she always finds some way to come back to here, even with a collar, placement of a pillow, obviously with manual stretching, but there's only so much at a subacute that you can do as far as hands-on attention.
Right, and so that's where I think we talk about position can be important. So if she's like this, which way can I sideline her?
On the other side, on her left side, to get her to.
Right. So I'll use gravity.
Right.
So it's for someone with torticollis, so you would want to get her at some point sideline, so gravity can help.
But so
pull
if
down.
her left side's affected, everything's flaccid here, and she's tightening to the contraction to the right, and you would say sideline on the affected
Sideline
side.
on the affected side. Well, what happens with approximation? When I compress 2 bones, what happens?
Piano receptors are fired.
So I can use that sideline. So if I get the approximation at the joint,
Right.
I can work, hopefully get some of those, the nerves firing. So I would put her sideline on her involved side, some parts of the day. Yeah, I'm not gonna protract the scapula too much, if there's subluxation going on, I'm gonna really keep her neutral. But certainly no problem that she can't sideline. I'll use pillows to keep her upright,
Right.
so she doesn't rotate back.
And use.
And then I'm gonna use gravity to help pull the head down to try to stretch that.
Right.
Because then maybe if I do that for 2 hours, then I'm getting more of a stretch than me, holding it for 5 minutes.
Yeah,
Right.
exactly.
No, I was just saying, it could be like 45. Doesn't have to be, straight on her side. Like build up a,
Yeah, because it's gonna, it's not gonna be comfortable with no pillow there. So I certainly want to do something, but I would use gravity there for that and help do that. Yeah, so again, everything in neutral. If I have any synergy, any extensor tone, hips and knees at 90 degrees, use the wheelchair for that. Again, improving strength, any type of resisted device we have, weight bands. You certainly work functions, sit to stand, step ups, weight shifting, postural stability exercises, therapy ball, unsteady surfaces, everything we have down there. We're always going to monitor. So we're always going to monitor their heart rate, blood pressure, all the vital signs throughout. We're going to look to see if there's any diaphoresis, any dizziness, right, sweating, a headache. Monitor their heartbeat, see if it's irregular, any change in vital signs during exercise. So to manage spasticity early on, we learned this last week, the PNF type stuff. Weight bearing. Weight bearing approximation for hypotonicity. Weight bearing to break up spasticity. So we go back to the developmental positions. Sitting, putting some weight through, some body weight through the upper extremity. Quadruped gives us some compression through the hips, shoulder, glenohumeral joint, scapula. So those exercises can start generating that muscle tone. And again, all functional stuff. Work on rolling. And this is where PNF becomes really useful. So rolling, roll to sit, supine to sit, sit to supine, bridging, get them standing in a plantar position, work on weight shift, work on trunk control standing, regular standing, and then eventually progress to walking. So again, the progression all the way up. Prone elbows gives us that compression of the scapula, glenohumeral joint. So we're working on developing that control. Quadruped we've always talked about, weight through the glenohumeral joint, through the scapula, through the hips. So don't be afraid to get these patients in quadruped. Right? I know it might be harder on us, because we might have to stabilize more, but the benefit.
Put them over a bolster.
Right, or use the bolster for support if they have poor trunk control. But again, it's a great way to initiate their weight bearing through there. All right? Again, don't be afraid. So we had bridges, sitting. You guys have this. I want to get to our different approaches. So different approaches, and when you guys are done, and if you're in the neuro PT field, a lot of different courses out there, a lot of different theories. So the big one obviously is the Brunstrom, wrote some of the neuro books that we have. You have Bobath, Rude, a lot of different types of stuff. Cabot with the PNF, we've learned the PNF. That's one theory towards neuro rehab. Brunstrom has the other one. So Brunstrom's approach is based on these 6 different levels of recovery with the patient. So stage 1, you start to see the flaccidity, no limb movement, right? That occurs early on in rehab with the stroke. Stage 2, start to see the emergence of spasticity. You start to see hyperreflexia. Still some flaccidity there. Stage 3, I am full within that synergistic movement. So it's a strong synergistic movement. Stage 4, I can start to move outside of the synergy. So maybe, hey, I'm starting to get better. I can start performing isolated movements out of that synergy. So someone on the upper extremity, maybe they can extend the elbow, lower extremity, we talked about, we have hip flexion. Well, maybe they can start doing some hip extension. So you're starting to see movements outside of synergy for stage 4. Stage 5, more movements outside of synergy. Stage 6 becomes normal movements. This doesn't mean everybody goes through those 6 stages. Maybe someone just stays at stage 3, someone stays at stage 1 if they're flaccid. But it gives you an idea. So if I know my patient is at stage 4, I can start performing exercises that can help break away that spasticity. Functional activities that can work away from the synergy. All right? So these stages, the 6 stages, that'll be on the test on Monday as well. So you can cross that, yeah.
So are you gonna need the PT to work through these stages, or is this gonna happen on its own, or? So, emergence is best, obviously 1 and 2, that's good, but then voluntary control doing the synergies. Are they gonna get to that point,
They might.
any intervention?
Well, you're always going to do intervention, but we're not going to dictate what can happen. Like, it's going to happen regardless of our intervention. We're using this for our intervention. Our intervention is not going to change this. This just normally occurs. But this is what they see in terms of, I guess it gives us more of an idea of what we can do with therapy based on the level that they're at. Because again, if I have somebody who all they do is stage 3 and they're in that synergy pattern, I'm not going to be able to do something different. So I know, okay, I'm just going to work in that pattern.
Yeah, you can't get to the isolated movements at that point.
No.
Yeah.
No, again, for those that have worked with patients with the stroke who have that synergy, it's very hard to break that actively when they're in there. I can do it passively, that's not a problem. So passive movements, yeah, I can stretch, I can do the weight bearing, that's fine. But actively, it's going to be hard to break out of that synergy. Like I can't say, hey, reach behind your back. That's not going to happen. Because once they get into that stress, it's going to cause the synergistic movement. Right? So yeah, they just use this as the guideline as to where they are in terms of their recovery. So your reactions that you can use to help, your soak-use phenomena, extension, abduction of the fingers. So when you bring the arm forward, you're going to get flexion, extension of the fingers, so you can use that functional. I talked about the Ramesses phenomena. If I resist abduction of one leg, I'm going to get abduction of the other. That's that irradiation we talked about. So you can certainly use that for therapy. So if I want to strengthen, if I'm a left CVA, if I want to strengthen my right hip abductor, what can I do? I can resist left hip abduction. So you can use that, I can resist left hip flexion for right hip flexion. So I can use that to help strengthen the involved side. Let's then move forward. NDT is used a lot with pediatrics. I want to go to I'm not going to, this one here. This one's fun. So constraint-induced movement. So they talk about, what they did was they took monkeys and they sort of induced a stroke for a monkey. They tied the monkey's arm, the good arm down, and they forced him to feed and use the bad arm. And they found that by forcing them to use the involved side, they got their function back. So that became this constraint-induced theory, this learned non-use. So demonstrated that if monkeys with disabled upper limb had their stronger arm constrained for several consecutive days while training their disabled limb, they would sort of learn this new behavior. And it worked really well. People do use this constraint-induced movement therapy. However, it's pretty barbaric because you have to tie somebody down and you're really using it for like 6 hours a day. So you're going to tie somebody down for 6 hours a day to have them move their arm. Yes.
So, not to this extent, but I've seen this used in pediatrics as well. If there's children who are having difficulty with rotational, especially with people who, kids who have torticollis. The therapist that I worked with, she would always hold down the child's arm so that
You're
they would be forced
Yeah.
to take their vision, their neck, and their other side to do extension and rotation. And again, not to this extent, but over the course of the treatment sessions, it started to show that it was working because she was actually voluntarily using that side over
Yeah.
using the side that she normally reaches for.
I've done it.
So my dad used to write with his left hand,
Yeah.
and they wouldn't like tie his hand, his mom would like yell at him and be like, you can't do that, and like force him to write with his right, and eventually he learned. Now he's ambidextrous.
See, look at that. You're forced. You learn how to do it.
So
But I've
don't,
done that. I've done that. I've tied people's arms down in therapy. You know, just during therapy. It was never during, like outside. It was just for like a short period of time in therapy to force them to use it. All right, questions there?
don't worry about Bobath or Rude.
Nah.
No? Okay.
Uh-oh.
Remember that picture I sent you
Yeah.
yesterday? His brother.
Sub-Taylor neutral. All right, here we go. Let's try. What's up? Little rugrats. Yeah. What's up, Andre? Yeah. All right, listen up. Very important information here. And some of your guys didn't want me to expulge it, if that's a word, but we're going to do the test on Wednesday. Divulge. Thank you. 410 SAT. Expulge. Expunge. Hopefully no one hears it. All right, so we'll do elbow today. We'll do lab afterwards together. And then on Monday we'll do neuro review. And then maybe you'll see how long that takes. And then in lab, we can do a lot of case studies and stuff with the PNF, blah, blah, blah. Test on Wednesday, we'll do it here, it'll be on Moodle. Good?
Is Kinesin here, is it in different room?
Oh yeah, did you guys get the email?
Yes.
All right, there you go, good.
Everyone just.
Why, what's the reason for it?
Yeah, well, the reason is they have like a presidential search, and I think for some reason they have interviews over in that room.
Residential search.
Yeah, they get in the president's school, like the ninth one in 3 years.
Oh, and they do interviews over there.
Yeah.
So what happens to nursing? Because I know nursing is in here. Where do they go?
Dude, that's not my stuff. Not my area. I just know I know I'm good.
Yeah, right.
Because they're not here. Yes, Andre.
So, for the mile training, I want to tell you,
Yeah.
we're gonna go by what Professor S.D. taught us.
Well, it's different.
Oh, I'm just saying, 'cause I don't know, because
Why?
I know A
What's the difference? What's the difference? She teaches better than I am.
No, I'm just saying because Professor
the 2020s might be at that same price point, so
Well, I mean, it's, German phone, yeah, so go by what we go back to. All right, here we go. All right. Okay, I'll look at her Monday. Okay. All right, here we go. Elbow. No, upper extremity. Upper extremity.
They just help out.
We good? Sit down. We good? Who are we missing today?
nobody important.
Oh, Andrew's not here yet. I know you have to still away. Steven.
Playing about California.
Snapchat.
It's like, oh, this is so hard waking up early, and it's like the beautiful beach outlook at 7 o'clock in the morning. Like, what? He's trying to get out of the way.
Because that's the way the college is. What's that? What are we doing today?
I said, what are we paying for?
What are you paying for?
Yeah, that's a fact.
You're
That's a
paying
great
for
question.
me.
Well, that's,
You're paying so I can retire in a few years. That's what you're paying for. That's what it is. That's what. Yeah.
Well, we can have it retired now, take it all.
Yeah.
yeah, seriously, with one semester.
And since my daughter just changed her major, might have to spend like an extra semester in college. That's what you're paying for. So I can stick around here longer.
You better hope she doesn't change your major again, man.
What'd you go from what to what?
She went from equine business to agribusiness. Equine, horses.
Horses?
And now, yeah.
Hippos.
I lost, put it this way, I lost that battle. Under the premise, you went to, you paid college for, business and then finance, and now you're doing physical therapy, so you have to go back to college all over again. So, all good.
It's fine.
All good.
She gets one mulligan.
She gets one mulligan. She's a good kid. Doesn't cause any trouble, so I can allow her to, take an extra semester at college. Although she's very upset about it. She's like, oh, I feel so bad. Well, I think she says she feels bad. I have to pay for it. I really don't think she feels that bad. Hey, can you send me money? I have to go food shopping.
$200 bi-weekly.
Yeah.
Because I feel so bad.
Because I feel so bad.
Yeah, exactly. Good morning, Dr. Gage.
Good morning.
How are you?
Good morning.
So we should thank Dr. Gage for allowing us to permanently station in Essex room. You know what I'm You realize I'm going to milk this for as long as I can.
Oh, you mean the new lab?
Our new room, yes, our new room.
That's actually room forever.
Forever. Yeah, until I retire. That's our new room. That's what I say. The administration thinks otherwise. That's okay. I can dream. All right, here we go. So upper extremity injuries. So important anatomy, we're looking at our, on the medial side, our annular ligament, which encapsulates the humeral head, keeps the radial head stabilized. So with fractures, dislocations, your concern would be tear of the annular ligament, which would then dislocate the radial head. Our ulnar collateral ligament, obviously with our overhead athletes, your Tommy John surgeries, and not just pitchers anymore, you're seeing catcher shortstops, baseball players. You're also, in other sports, not as prevalent, but you're seeing, any overhead athlete develop that tear of the ulnar collateral ligament. Obviously, the joint capsule on the lateral side, your radial collateral, lateral collateral ligament. You have your tendons of the bicep, underneath tendons of the tricep. So some of the important anatomy in the insertions that we need to go back, because you're going to see your triceps tendonitis, bicep tendonitis at the insertions. So elbow, common injuries we have would be our lateral medial epicondylitis. So I was having so much fun last night doing research. I got so much great stuff. So what common professions that you would see epicondylitis in? What do you think? So they call it, tennis elbow for that reason, right? So you think tennis, the overuse. What else? Main professions.
Probably some sort of construction.
So construction, right? So plumbers. Painting is common, but most common. What do you think?
Most common. Wait, what's
Most
for-
common
for
for
lateral?
regular population where you would get epicondylitis, either lateral or medial.
Is it like a cashier?
Not cashier, not moms. That's like the nurse's elbow.
Bartender.
That's what she did. Cooks and butchers.
Uh,
Yeah, cooks and butchers
That was close.
and auto mechanics.
hmm.
More prevalence of epicondylitis than your tennis player.
Medial and lateral?
Either one, either they didn't classify as one being specific. So again, anything, so which goes to show you that, our look, years ago, we would think of tennis elbow, medial epicondylitis, your golfer's elbow. We're always thinking of like that motion, right, for tennis this way, but they actually find it's more of the hand. So it's the grip, your grip on a knife, your grip on tools, and then obviously the tennis and the golf in terms of what would lead to that overuse injury. So getting into the actual tennis elbow affects common wrist extensor tendons right at the origin, repetitive overuse, use of hand tools. So it's involving the rotation, pulling, extending, and then the hand grasping. So again, they're really looking at the size of sort of like the tool, the tennis racket, the equipment that they're looking, which then could lead to that overuse injury. Symptoms, you have your pain with palpation, pain with resisted extension, and pain with grabbing the hand. So a patient comes into the clinic, my assessment is going to be, obviously I'm going to palpate that lateral or medial epicondyle. They're going to be point tenderness. Anybody here have suffered from, from weightlifting? Yeah. I mean, you have that point tenderness. For tennis elbow, we're going to resist extension. So hold here, I'm going to pull down. That's going to exacerbate that area. You should have pain with that. You might also see resisted pronation or supination. Hold here, I'm going to pull down, you pull up. Sort of the extensors. So to test it, you're going to do point tenderness, point like the palpation, and then resisted extension, and then resisted pronation supination. And then opposite for medial epicondylitis, it's going to be resisted flexion, right? Because it's the flexor tendons, which you're going to see. So management, acute, early on, it's elimination of the pain. So a lot of times the non-steroidals, anti-inflammatory, cortisone shot. Yes?
So for lateral, it would be resisted supination?
It would be resisted,
More so?
actually no, it would be resisted, resisted supination. Medial epicondylitis would be resisted pronation. So I'm pushing into supination for medial, for golfer's elbow. I'm pushing into pronation, resisting that for tennis elbow.
Forcing them to do supination for lateral, forcing them to do pronation
Yes,
for...
and I'm resisting the opposite. Yeah. Yes. So pain, inflammation management, non-steroidals, anti-inflammatory. I think that's very important for the cortisone shot. Anybody get cortisone shot in here? It's like the best thing ever.
Absolutely.
Really? Oh my God, I had like, impingement in shoulder is the best ever. I had like one in my life. So yeah, you want to work with that. Modalities, rest protection, mobilization, and most important is activity modification. So we have somebody that comes to an overuse injury. We have to figure out ways that we can modify that activity. Change the grip, change the handle, and see how that works. Even, even rest. So after we get rid of the pain, full range of motion, we begin with exercising, whether it's concentric, eccentric. I know we had talked about it, that eccentric is always more effective for tendon injuries, and study here was that the consistent finding supports the inclusion of eccentric exercise as part of a multimodal therapy program. I won't get into the specifics of why. I know, Chris, you were talking about that, right? Eccentric? Class 2 weeks ago, like use of eccentric exercise?
Oh, yeah, but it's
Right, so I have a study here. But yeah, he talked about use of eccentric for your tendinopathies, how it's very important. So we can show you that in lab. So treatment-wise, wrist extensor, flexion, pronation, supination, strengthen those. You want to stretch, so right, your wrist extension stretch, wrist flexor stretch. But what's most important is going to be your grip. So you're going to see an imbalance between the extensors and the flexors. And so one of the exercises that you can do, and even for a home program, give them a rubber band and just have them work on wrist extension. You've seen the therapy web? Anybody seen that?
Yeah.
Everybody?
Yeah.
It's like a tennis racket type of thing, and then you put your fingers in it and you extend. Very important then for especially tennis elbow. Medial epicondylitis is golfer's elbow, overuse affecting the flexor muscle group. So palpation, pain will be medial, pain will be with resisted flexion, and treatment's going to be the same. So obviously you're stretching, and then you're strengthening. So our treatment exercises, we can use modalities, and because I know you guys love your modalities.
Ultrasound especially.
So,
Or Therex.
well, we're in Therex, we gotta do modalities. Actually, out in the clinic, if you got out in the clinic,
I'm just trying to make fun of Devin.
that's right. Yeah, they're gonna mobilize. Out in the clinic, for you guys out there in the outpatient, are you seeing your tennis golfer's elbow? What modalities are they using?
Ultrasound,
So a lot of ultrasound.
and also like ice stretch.
Anybody else?
Soft tissue.
Yeah, we'll get to that. Are you guys still seeing lasers? Lasers was big, I don't know, about 10 years ago. Those, the light, I forget what it's called. What is it called? The cold.
Oh,
Cold laser?
Cold laser, yeah. I had
That
that
was
done.
really big years ago. I don't know if it's still used out in the clinic. Is anybody using it there?
I used
There
to,
is, I used to use one at professional, yeah.
like at the workplace I was at, in Ramsey, they used.
Used.
I
So
mean,
you're
when
not
I was
s-
there 2 years ago, I saw it being
Yeah.
used
So you're not seeing it as
in
much.
the clinic.
So another study talked about, really the most effective treatment for these epicondylitises and mobilization. So mobilization before treatment actually can help reduce pain and therefore allow us to do more exercise. So we'll get into some moves today. So mobilization is very effective, incorporating regular strengthening, stretching, part of the therapy.
What's your opinion about, so I've seen some therapists use cupping for
I-
epicondylitis.
Again, I don't know enough about cupping to make a decision. I've never used it. I've had it done to me. I've never used
It's
it.
mostly myofascial release more than anything.
It's more to bring more
It's
blood
flow to the area.
up to the superficial area.
Yeah.
So I don't know enough about to pass judgment. Again, I know a lot of people use it out there.
Yeah.
So, I don't know the physiology behind the use of it. It's more of a myofascial release?
Yeah. That's what it's intended for.
Yeah,
Usually used on like areas where there's a bigger muscle belly.
okay.
So like using it on an elbow might feel smaller surface area.
I just find it's amazing that you get your circles after treatment, right? You get your,
But I've seen therapists use for
Okay.
for that and stuff.
Yeah,
So
like I
was
said, I'm not,
yeah,
I'm
yeah,
sure
I
if
was
it,
wondering.
again, if it works, that's great. You know what I mean? I don't know where we stand on dry needling. I know dry needling can work. So, so again, like, the modality, so one of the studies showed that modalities, the benefit was not as effective as mobilization and exercise. But you also have your other treatments out there for this, a little newer, the plasma-rich
PRP?
platelet, the PRP, has shown to be somewhat effective. But then you're looking at cost.
Yes,
So in
expensive.
conjunction with therapy, again, maybe if it's the athlete, they would do the PRP. I know with one of the doctors I used to work for, he did PRP a lot, but he was also in an affluent area, so people were paying for it. So again, there's a difference of what your clientele is, as to that might be something that you can recommend. The stem cell therapy they also use, so you get a lot of different therapies nowadays. And again, I guess it depends on where you are and what the experience is with that.
Yeah, HRT is getting pretty big too.
What is it?
HRT?
Which
Hormone
is?
replacement therapy.
Hormone, okay. Yeah. Again, it's very early. I mean, it's still early in the use of that. So I don't know what studies have come out to show. Again, I know people that have no problem paying for that certainly would give that stuff a shot. But at the normal population, not really. Again, it's just easy, if we go with the modalities, but going back, modalities, so the mobilization, soft tissue mobilization is more effective, than just using your ultrasound. Alright, so again, mobilization modalities, if you want soft tissue, cross-friction massage, part of it with that tendon, with the inflammation of the tendon, you get scar tissue to build up. You want to break it up. And so the cross-friction massage breaks up that scar tissue, brings more blood to the area. But every time you do cross-friction massage, you always have to finish with regular massage, because I'm breaking up the collagen, but then I need to get that collagen to lie down parallel so it heals properly. All right? So cross-friction massage, very effective, but then finish with regular massage to train the collagen to lie in parallel. And there are other exercises there. There is surgery. So they do have, if conservative treatment fails, they do a lateral epicondylitis release where they would go in and surgically reattach, I shouldn't say reattach, they detach the extensor tendon from the epicondyle and they'll reattach it to a different part, maybe the fascia, so you're taking the stress off the lateral epicondyle, shortening it a little bit to help alleviate pain.
So they're moving more distal.
They'll probably move it a little more distal. And in fact, like when you brace, so bracing is also, you see the little brace, all you're doing there is you're just changing the insertion of the origin site. So the stress is no longer on at the origin, you just move it down so you don't get that irritation of the epicondyle.
Don't they use another, tendon from an elbow to do it? Like they harvest it from somewhere?
No, that's a different surgery.
Oh, okay.
We're gonna get to that soon. That's a different surgery. So again, we have so it's actually pretty effective. I've seen it a few times, but it's pretty effective. But that's if the conservative approach really fails. And then, Tommy, a Little League elbow, overuse injury with your young baseball player. So basically you're getting abnormal growth, bone spurs at the epiphyseal plate of a youngster. And so what happens, you can see on the left, almost like an avulsion type, where you're getting the separation of the growth plate. And for someone that comes in with this, it's more rest, and again, you're seeing a lot of it because the way youth sports has evolved, it's no longer just play baseball in the spring, football or soccer or basketball. It's you're playing baseball all year long.
So you would treat that with rest, you said?
You would treat that with rest, yeah.
So would the kid have to stop playing the sport?
Yes, you would.
Yeah.
Go to soccer
And
instead?
good luck. And it's not so much telling the kid he has to rest, it's telling the father that the kid has to rest. Yeah.
So not much you could do with that.
No. No, he just has to rest. Sorry, Brian?
I was saying go to soccer.
Right, go to soccer. Then you gotta deal with concussions.
Oh.
Yeah, it's a shame. It's so common. I've seen it, unfortunately, I've been involved in baseball, and I've just seen, the parents are just crazy. now, which is a shame, is it's a huge business. And so now you want your kid, having your kid at a young age ranked is a big deal. Because it's more ego. But you can hurt your kid. So it's almost like, hey, wow, my kid's ranked as a 12, 13-year-old, which big deal, doesn't get you anywhere. But yeah, when they get older, they can't play the sport. So, Dave, I'm sure you played baseball. Was Perfect Game big back when you were playing?
Perfect game?
No, it's enormous now.
Not at all.
Is that a ranking system?
It's a company that provides a ranking system.
Didn't even exist when I was playing.
It's
It was all, like,
huge.
Word of mouth.
I never
People showing
heard
up
that.
to games whenever they heard that there was a good player from one of their scouts, stuff like that. There was no internet at all.
Yeah, now it's enormous.
Yeah.
It's, yeah.
Now with that movie Moneyball, it's all the stats.
Again, it's a shame. They're taking advantage of people. You travel all over the country so your kid can get seen. It's like, 12, 13, 14 years old. My son had asked, oh, can we do that? I'm like, well, no kid has ever gotten drafted in the 8th grade, so no, we're not doing it. So, you're good. You can stay home and play with your buddies and save you the money. Your time will come, so. But part of it is, again, if you are involved in that outpatient setting, you're talking to the parent. So they have these kids, they pitch their rec team, then they do these town travels, and they have this club because the father wants to see their kid in like the ranking, and so these kids are throwing hundreds of pitches a week, and that's what leads to the injury. As opposed to like, let my kid just have fun in high school, and then see what happens after that. But again, good luck dealing with that crazy dad. All right. So our ligament injuries are ulnar collateral ligament resulting from that medial force, that valgus force, right? The overhead thrower. We tested with the ulna, right? The valgus stress test, 20 degrees, hold here. So that's to test the medial collateral ligament, the ulnar collateral ligament. What you're looking for is any gapping, if there's any instability. If it's torn, surgery would be that Tommy John surgery. That's where they would take the palmaris longus and then just transpose it there. And you see a lot of these professional baseball players get Tommy John surgery, they come back a year later, and they're stronger. Which leads to these stories of high school parents getting their kids Tommy John surgery, even though they're not injured, just because it's going to make their elbow stronger. Yeah.
Baseball parents.
I can't believe there's a surgeon that would do that.
You'll find there's a surgeon out there that'll do anything.
Black market surgeon.
Yeah, you go out, you go to enough, you'll find somebody that'll do that. Absolutely. Absolutely. Yeah, so again, it's these, kids, instead of having your kid be a kid, these kids are, again, traveling over just doing sports, and then they're getting injured. I think I saw, 20 years ago, working with, the Jackals, some of the other teams, one Tommy John surgery, which was rare. And that was, 1998. Now I guarantee if you're an outpatient place specializing in sports, you're going to probably have one Tommy John a week. It's just the prevalence is outrageous now.
Yeah, we got like an 18-year-old kid in there.
Yeah.
Yeah, the youngest Tommy John had was like 13.
Yeah. You got a 13-year-old Tommy John? And it shouldn't happen. It should not happen.
When I was a teacher, I was actually surprised. In 1 year, I had three kids who had Tommy John. 2 of them were wrestlers. They didn't even play baseball, and one of them was a baseball player.
Yeah.
But it was just like walking around seeing kids with their elbows like this whole day. It's like, that's not fun.
Yeah. So Tommy John surgery, they take the palmaris longus tendon. Hopefully 90% of the people have it. If not, they use like the hamstring. And they just transpose it right to where the ulnar collateral ligament is. So you're braced for about 6 weeks. It's a very long, detailed rehab. It's pretty specific in terms of what you can do. That is where you better contact your physician and get the specific protocol, because you don't want to mess this up. And there have been cases where, towards the later stage of rehab, where it fails. Doesn't happen often, but that can fail. But again, you don't be the person that causes that to fail.
You're saying they take the tendon, what, the distal or proximal?
They take the entire palmaris longus out.
The whole muscle?
They'll take the whole muscle out.
Damn.
They'll harvest the tendon part of it. It's a long tendon, right?
Yeah.
Which the palmaris longus for us doesn't do anything. Right? Everybody got one? Who doesn't have one in here? So you do this, right? Pinch your fingers together, and then flex.
Yeah, I got one on the right.
You don't have one on the
I
left?
think I have
Which one is it?
I got some massive ones.
I really got it.
So that's the palmaris. That one popping up, that's your palmaris longus. So 90%, 10% of the population doesn't have it. If that's the case, then they'll use your hamstring tendon. And so they're taking this tendinous unit, Chris, they're taking the tendinous unit part of it, and then they're drilling, and then they're just, drilling it right into where the old ulnar collateral ligament is.
Yeah, I was gonna say, if it
This means nothing.
Well, it's
It doesn't matter.
doesn't affect your.
Having no palmaris longus doesn't affect anything. So it's one of those where over evolution, maybe in like 1,000 years from now, we won't have palmaris longuses.
Well, unless you're Italian.
Unless you're Italian. Coming from the Vikings,
Yeah,
making Italian
that's
joke.
pretty good, that's pretty good.
The Norwegian guy making fun of us Italians here. Oh, hey. So I apologize.
That was a good one.
Only the Italians can use their palmaris longus. Yeah, but again, it's like it shouldn't happen. Just, if you're involved, teach the kids, adequate rest. And they try to do that with pitch counts, but again, it's the crazy parent. So your lateral collateral ligament, usually from some dislocation, subluxation, very hard to injure it just because of the way the stress is. But a wrestler, football player, any athlete, basketball player landing on an outstretched arm, where you get that force to the elbow, so you can dislocate the elbow, and that can cause lateral collateral ligament injury. So valgus stress test would be, valgus stress test lateral collateral, 20 degrees of flexion. Why do we do 20 degrees of flexion? And it's not STNR.
I was waiting for that joke later.
It's not.
So it's loose back.
So it's loose pack position, right? When we have the elbow extended, we have the bony congruence, which is going to give it stability. So 20 degrees, loose pack position. For varus, we applied the force on the medial side, pushing out. For valgus, force is applied from lateral, looking for any type of gapping in the joint. Pronator teres syndrome, compression of the median nerve passing through the pronator teres. We resist pronation while we extend. That's the test. If that median nerve is in between the two heads, then either surgery to sort of bifurcate it, to split it, or what technique would be good to help that median nerve compression? Right, the glides. Remember from Wednesday? Yes, yes. Remember lab, right? Median nerve. Do that. Who, about you? Are you practicing? So again, like
I've been doing all this,
You've been doing all this-
only not the glides.
you've been studying, so you have to do your nerve glides. Thank you so much.
I'll do it in between pages.
Okay. That's all it did. Do as I say, not as I do. All right, wrist injuries, our fractures. So our distal fractures, we have our Colles injury, our Smith fracture. So Colles injury, distal fragment is displaced in the dorsal direction, right? You fall out on your hand is flat, or wrist is extended, fall, and then it comes out dorsally. Our Smith is falling on a flexed hand, and then it's displaced in the palmar direction. So usually they're casted, maybe surgery, put some pins in there, plate, casted, and then again, once they're out of the cast, gentle joint mobilization, a lot of stretching, and then straighten from there. But again, if a patient falls and they break the wrist, what else are we concerned about?
Damage to the nerves.
No. we just focused on the hand?
Elbow.
No.
Fingers,
Patient fell, breaks their hand, their wrist.
Shoulder.
their fingers.
STNR.
What else? I see, I got to put a question on, just for you.
All of them.
Good grip. I'll get it wrong. Is that what you're trying to do?
Now,
Atrophy?
you read the chart, patient fell, fractured wrist.
Balance.
Balance, thank you. So yeah, we're gonna focus on the wrist, but what was the cause of the fall? And so we have to make sure we address the cause of the fall. It's not just looking at the wrist. Yeah, that's gonna be a big part of our therapy. But how'd you fall? What was the cause? Did you get dizzy and fall down? Did you just trip on something? Again, especially the older population, because that's where you're gonna see this a lot. The older population, maybe some, post-hormonal therapy for women, osteoporosis. Again, that's something that, we need to dig into. Because if I'm just treating the wrist, but I don't address the reason for the fall, I'm not doing a complete job. All right? So again, that's why we look at the entire body, all systems. We talked about that with the evaluation, with the assessment that first day. So we have to address the fall as part of therapy for the wrist. So then you have your other distal ulnar fracture, carpal fractures, your metacarpal fractures, boxer's fracture, fracture in the 4th or 5th metacarpal. I always tell a story of a guy I knew in college, lived on my hall. We called him Psycho George. Okay.
Very endearing.
And Psycho George, whenever he would go out and have a few too many cocktails, he was a little guy, but he always had the beer muscles. And he'd always try to get to fight, but he'd always punch the wall. And I can't tell you how many, metacarpal fractures he had over, the 3 years I knew him. So I'd see him the next day, he'd have, bandage or cast. Joy, what happened? I said, who won? Did you win? Did you win or did the wall win?
The wall got me.
Right? Because Joy, the wall always wins. So fast forward 20 years, I find out that Psycho George is like the director of a hedge fund, making like $20 million a year.
Still punching walls?
I don't know. Well, the hedge fund ended up buying Winchester
No way.
and Smith & Wesson. So now Psycho George doesn't have to punch walls, he can shoot them down. So moral of the story,
He's still punching walls.
yeah, don't punch walls.
Or punch walls makes you 20
I think
minutes.
you have to punch walls.
So whenever I hear, whenever I teach this, it always reminds me of the metacarpal, the boxer's fracture, Psycho George punching the wall, and then him coming up and, buying, owning gun companies. Yeah.
You gotta get Psycho George and the crowbar in here.
Yeah.
I can pretty much guarantee I can get the crowbar in here. Psycho George, I don't know.
Yeah.
And that's the question, do you want him in character or out of character? You gotta come in character? All right, I'll talk to him this weekend, see if he can come down in character. We can talk about being a business owner. That'll be it. I'll reach out to him. All right, so managing the wrist fractures. So once they're usually immobilized, 6-8 weeks, depending on how they heal, depending on the surgery. After they're immobilized, goals really improve range of motion, improve strength. Joint mobilization, working on, again, improving, functional strength. One of the things that you lose a lot of is actually the pronation supination. So make sure that you're mobilizing your distal radial ulnar joint, your proximal radial ulnar joint, because they're casted, and so it's that immobilization which will cause lack of movement. So we have our Smith fracture up front, our Colles fracture. So the Smith fracture will be landing on a flexed wrist, Colles fracture landing on a extended wrist.
Which one is the one that they refer to as the fork?
Colleagues?
Colles.
Yeah, it's gonna be the Colles. Right? There's only like a fork down there.
I don't see,
Yeah.
I never saw the fork.
I've never seen the fork either.
I think that's
When we get into the back, you can see the Scotty dog.
Oh, yeah.
Is that what they're looking at, like that part right
Yeah,
there?
Yeah, the teeth.
Well, they
But
both
it's-
kind of looked like
They-
spiky sides.
yeah. Unless it's like a spork fracture.
Yeah.
Now we're talking, that looks more like a sport.
Other soft tissues, you have your ligament injuries, you get falling on the thumb, tearing some of the ligaments. Your skier's thumb would be a sprain of the ulnar collateral ligament of the thumb with hyperextension, right? Fall down, land on the thumb. Your decurvanes, tenosynovitis, affects in the abductor pollicis longus, extensor pollicis brevis. That's what the Finkelstein's test. So maybe it's more common now with texting thumb. Gaming thumb, maybe you see it more, overuse injuries there.
Coupled with bad posture.
Like there was I don't know, just like a meme? Meme? What is it, a meme? A meme, all right. Where it was like some guy goes to the doctor, he's like, yeah, I got a problem with my thumb. It was this like giant thumb, from texting, like an overused injury of the thumb, compared to the rest, just the people text all day. So tenosynovitis, you have your Finkelstein test. Other injuries, your extensor tendon injury, your mallet finger, and then your boutonniere deformity.
I'm working on a guy with boutonniere. I don't know what the heck I'm doing, but it's working.
Good, keep it up.
Getting better.
Keep it up.
Nobody told me what to do in the clinic.
And then we have our carpal tunnel. So, what tendons run through the carpal tunnel?
Well, median nerve is under there.
Median nerve is, all right, that's not a tendon, but that's okay, it's a nerve. That does run through there, that does get compressed.
EST nerve?
That goes to there.
That's how we treat it. With that, the four tendons of the flexor digitorum longus, four tendons of the flexor profundus, what else? And the flexor pollicis, right. And it's all surrounded by that retinaculum, and so overuse injury irritates any tendon or the nerve, or irritates the tendon, presses the nerve, and you get that pain, numbness on the first three fingers, and that's the carpal tunnel. So the tunnel is formed by the carpal bones, the transverse carpal ligament, and the 9 flexor tendons. So increased friction and pressure can produce sensory and motor problems. Tingling, weakness, maybe you'll see atrophy of that area.
What is that complex called again?
TFCC. Yeah, TFCC. And that's another one that's, like any injury to that area, they're saying it's like a TFCC injury. So it's, you don't know what it is in the hand, it's TFCC. So you have your carpal tunnel, your nerve that gets compressed. So clinical presentation is going to be numbness in the thumb, radial digits, tingling, worse at night. Well, it's worse at night because when we sleep with the finger, with the hand flexed. So important, patient comes in with carpal tunnel, a wrist cock-up splint. Sleep at night with that wrist in that functional pattern, functional position of the hand, so they're not compressing while they sleep. Everybody thought it was actual typing that caused it, but it's actually not really the case. Not necessarily the ergonomics of it. It's important to get involved in the ergonomics, but it wasn't necessarily the typing or use of the computer that caused carpal tunnel. So we get more of the positioning at night. So tested, we have our failings, our reverse failings, our Tinel sign. Treatments, ultrasound, get if it's effective. Nerve blinding, very helpful with that. Splinting, so that night splint is very important. And then work on ergonomic modification. Anything else? You guys come across anything else for carpal tunnel? Conservative, before we get into the release. Anything? Vitamin D.
Ooh. Healthy bones?
Vitamin D supplementation in carpal tunnel offer favorable outcomes in pain improvement, better functional status, and increased sensory conduction velocity in the carpal tunnel syndrome. Anybody in here take vitamin D? Nice. Anybody take other supplements or vitamins? You're wasting your money. You're wasting your money. By the time you swallow it, it goes to the stomach, gets absorbed, and gets sent to the body, it is basically rendered ineffective. Unless you're taking an exorbitant amount of that, and then you're looking at being unhealthy and then the cost. Vitamin D is the only supplement that really has any effectiveness in getting absorbed and used by the body. That industry is a billion-dollar industry. There is no regulation. So there are no studies. The companies will do studies. They'll tell you they do studies. But if a company is doing a study, do you think it's going to be valid?
No.
There's going to be a lot of bias there to say, hey, this study, grows hair back. Our product definitely works. So just be careful. And I think it's fair to be honest with our patients, because I get a lot that ask, they take the chondroitin, the glucosamine chondroitin for arthritis. Nothing's going to grow cartilage back. It's gone. But in order for that stuff to really have any effect, you got to take it for a long period of time, and then you're looking at the cost. So what's more important, spending the money, or saving that money so you can buy medication you need, housing, food, or putting it towards those vitamins?
Well, a lot of it, we were supposed to get it from our food anyway.
Sorry?
From our food.
Well, so that's where you need to get it from. And again, I think that's the most important conversation, and I won't say most, but it's a very important conversation to have with your patient, is that, you want to get your nutrients from your food. Your vitamin C, get it from eating grapefruit, oranges. Right, Dr. Gage?
Yeah.
Nursing?
Yeah.
Very important. You eat healthy.
That's fine.
But it's very difficult because now you're looking at socioeconomics. My son eats a pint of strawberries a night.
That's good.
Yeah, it's good. Yeah, $5.99 a night just for him to have a snack.
You gotta
It's
get
not-
the frozen.
It's not
to
good.
put in
You
a
eat frozen.
smoothie.
Yeah,
Oh,
and that's the way it is. My daughter, she'll eat a pint of blueberries a week.
man.
And I'm not going to say no. I'm not going to buy it because.
He needs the glucose for baseball. Get the glycogen stores.
Yeah, you're right. So yeah, that's always the thing. Socioeconomics plays to that. But again, I think it's very important to teach. Like we talked about before, the nutrients with our patients. You gonna say something?
No, I was just saying it's also agriculture, like the way we're growing our food too, is like including a lot of this.
It does. So it's interesting. I was telling my daughter switched to agriculture business. Kearney, Harrison, right here, is becoming one of the biggest hydroponic
Really?
production places in the country.
Where though?
I don't know where.
Oh, okay.
I don't know. I want to find out. But they had a lot of these old warehouses that were sitting stagnant. Companies came in, this new age, and they grow in hydroponics. They're growing tomatoes in Kearney all year long that are beautiful.
That's the only way to go because the land is being depleted, so you have to build up.
Well, so the land is being depleted. You're looking at the nitrogen, the effect it has on the environment, like the regular farms. You're looking at people that have to work the farm, so the costs are going up. However, nutrition-wise, they're saying hydroponics is not as nutritious because it's not getting the stuff from the soil, which is very interesting. Yeah.
Isn't that part of it though? You bring the soil into the building and
No, it's water. No.
I know it is water, but isn't it in a tube?
It's in water.
It's in water, but the water is in a tube and it grows out.
Yes.
But don't they supplement it?
They try, but you're not getting the nitrogen,
soil?
the true nutrient from the soil.
Oh no,
Yeah.
I gotta look into that. It's
It's
not
really
good.
interesting.
So one of the things I used to do in my health class was have these guitar
kid, made a good point saying that, listen, these are genetically modified, but the actual availability of food, this is currently the lowest rate in history.
Yeah.
Where there's, starvation. Like, it's crazy when you think of that.
Everything on the planet is a genetically modified organism.
Yeah.
So, but again, going back, have that kind of nutrition very important with our patients, all right?
Real quick, going back to the tennis and golf elbow, would splitting it might be a good idea
Yes.
as well?
Yes. Yep, yeah, splitting with positioning absolutely would be helpful. All right, our hand, so getting down to the hand innervation, right? Radial nerve is purely sensory. Median nerve, you have your opponents, your abductor, superficial head of the flexor pollicis, and your second, third lumbricals. Ulnar nerve. So again, go back and read your finger nerve distribution. Because if somebody comes in with some type of atrophy, thenar eminence, hypothenar eminence, we can be able to trace that back to where maybe there is some nerve entrapment. Don't necessarily have to have pain, but if they have decreased sensation and you see atrophy there, you want to be able to bring that back. Our hand deformities, median nerve palsy will be the ape hand, wasting of the thenar eminence. Bishop's hand will be the ulnar nerve palsy, wasting of the hypothenar eminence. And then wrist drop would be radial nerve palsy.
Would you do like nerve class?
Yes, I would. Yeah. Absolutely. And then our finger deformities are a swan neck, flexion of the MCP and DIP with extension of the PIP. See, too bad Professor Doyle wasn't here.
She's got.
No, he Doyle, because he has, like I said, he's got a swan neck. So it's always great to show his finger. This is a swan neck. A boutonniere deformity, extension of the MCP and DIP, flexion of the PIP, like that's that one there. And this is all splinting too. And then trigger finger, thickening of the flexor tendon sheath, causing sticking of the tendon with the flexion. So the finger is pretty intricate. You have like a pulley system, and your tendon, as it comes down into the phalanges, it splits, goes through that tendon, the pulley system. So if the tendons drop down, that's going to be the trigger finger. So surgery for this, it's like that microsurgery, very intricate. Therapy is also very detailed. If you get involved in the hands, you're going to follow a protocol specifically. You can become a certified hand therapist. It's probably the hardest probably the hardest credentialing test out there. But again, if that's something that you want to do, if you're working with hands and you enjoy hands. But surgery-wise, if somebody has a tendon injury, again, you want to be specific in terms of the time frame. We have tendon glides. I don't know if everybody ever see that. So go down, up. Those are your tendon glides. Also want to incorporate your nerve glides with injuries to the hand. Our grips, you have your power grip, right? You use whenever you need strength or force. So, I know you guys saw it last year, but very important, again, if we're looking at function, if we're looking at getting somebody back to work, and they work with their hands, regardless of, if it's an upper body injury, the grips are very important. It's something that we need to incorporate, with our treatments. The hook grip, fingers are used to control forearm, so you have flexion of the fingers, and then extension of the wrist, no thumb involved. Our cylindrical grip, the entire hand wraps around the object, so it's the opposition using the thumb. The fist grip, the hand moves around the object, you're carrying a heavy suitcase. And then the spherical grip, the hand moves around in a sphere if you're picking something up, carrying something. So again, understanding these grips, knowing what's involved, can really help with return to function. So that overhead worker, and they've been out for a while, it's important to include grip strength exercises if they're going to be carrying something, get back to that fine motor skill as well. Our precision grips, you have your pinch grip, the three-point chuck, if you're writing pencil. The lateral, you're holding a key, and then your tip pinch, your fine motor for coordination. So, again, important to incorporate that if you work with a hand therapist or work with an OT, you can do that. But again, if somebody's coming back with an upper extremity injury, carpal tunnel, incorporate fine motor type stuff as well. Rice bucket is always big. Put your hand in a rice bucket, you turn, you grab, picking up like beans one at a time. I know it seems kind of boring, but it's very important to incorporate that to get the person back to full function. All right, that's the hand and the elbow. Any questions there? Was everybody good? Okay, good to hear there. So remember, vitamin D, and especially now in COVID, because everybody's stuck inside, there is so many vitamin D deficient people out there. Yeah.
Just remember, you have to take it with fat. You can't
Yes,
just
you
pop
can't,
it.
you're right,
You
you're
know,
right.
so
Yeah.
take it with food. Yeah.
Vitamin D is beneficial in preventing catching as well.
And what? Oh, yes,
Prevention of catching.
correct, yes. So vitamin D, or live outside, get your sun.
The best time to
Yeah.
take your vitamin D, my grandmother told me, is literally between hours of, well, depending on the season you're in, but like 6:30 a.m.
Okay,
Oh, yeah.
that's good. Because on Sunday morning, when Dan and I are running the woods, 6:30 a.m., we're out there.
8 o'clock, the UV rays start to get a little bit more harsh. So you really want to be there during the time where the vitamin D is like most prominent and it's not as much as be
So.
when the sun's rising.
All right, so just to recap, study this weekend. We'll do a review on Monday. The test is Wednesday. So this way, come in Monday with questions. That's new.
I was going to say,
Yeah.
I don't know,
So, all right, come in with questions. Really.